So, it's nice to be invited to come speak. I've given this talk to a few different people recently, but mainly registrars, I think, general medical, geriatric. So hopefully no one here has seen it before. Apologies if you have. I've altered it a little bit. So we are going to discuss acute inflammatory neuropathies, and now some of this is there'll be some aspects where we'll discuss concepts of neurophysiology, which I'm conscious not everyone will need to have in-depth knowledge of. Okay, but we'll try and focus a little bit on some of the clinical aspects a bit, and run through some different kind of case scenarios and discuss how things can differ a little bit in terms of when people are present with acute neuropathies. So, am I skipping through? Sorry, just lost my pointer for a second. There we go. So, in terms of learning outcomes, we're going to talk about GBS. Okay, we're going to recap what that is. We're going to discuss some things which are different to GBS as well, because that's probably the main acute inflammatory neuropathy people will see. And we are going to talk about some other things, and I'm not going to try and bore people too much with obscure neurophysiology. So we are talking about peripheral nerve diseases here, and we're talking, just to kind of touch upon again what the anatomy of a normal peripheral nerve is. So we obviously have sensory afferent fibers, and we have motor efferent fibers. Okay, and this diagram here is demonstrating, possibly slightly erroneously, but I'll come to this in a minute. So this is a nerve. This is a cross section of a nerve within the nerve, and I hope you can see my pointer, everyone. You can have this kind of epineurium kind of connective tissue around the outside, and that often be full of vascular structures as well, when they're perforating down from the vessel. Within it, then you get these bundles of nerve fascicles here. Okay, and within these bundles, they're surrounded by a connective tissue layer called the perineurium, and then everything else within that is termed the endoneurium, and that's connective tissue between the nerve itself. If you pick out a nerve fascicle, okay, so obviously we have different types of peripheral nerve, and we'll term that in a minute, but we obviously the basic structure we understand. We have the axon sitting within it, and we have a myelin sheath around the outside, and the myelin sheath is stemmed from the Schwann cell. So in terms of sensory fibers, say if we have something like a mechanoreceptor, that would kind of transmit up often through afferent, thickly myelinated axon into the nerve. That would ascend up, and then the first order sensory neuron terminates at something called the dorsal root ganglion, this structure which sits just outside of the spinal canal, and or just inside the spinal canal, apologies. And but extradurally, it's extradural intracanal. And that is a structure then which, along with the motor root, okay, forms our peripheral nerve when they come out. So in terms of motor structure, so the second order neuron comes up and then would go into, say, something like, this is a reflex. We demonstrated a reflex here in this diagram. But obviously, if you had something like dorsal column proprioceptive function, that would ascend up proprioceptive tract in the dorsal column. So the second order neuron actually terminates often in thalamus, and then thalamus up to your somatosensory cortex and the rest of the connectome in the brain. Now, in terms of motor, we obviously have upper motor neuron and we have a lower motor neuron. So the lower motor neuron starts from our anterior horn cell here in the grey matter. That's the synapse that comes out into our ventral root and ascends out here into the down through a thick myelinated axon into skeletal muscle, neuromuscular junction sat on the end, which is important for myasthenia gravis. So that is our anatomy of a normal nerve. And to reiterate again, broadly, you can separate out types of peripheral nerve into two types. So we've got myelinated nerve axons. So we term them kind of 1A, 1B, okay, typically. And those myelinated axons, in terms of what their function is, in terms of what sensory modalities and action they take, is they are sensory and motor. And they often, proprioceptive function is the main thing which is transmitted up thickly myelinated axons. In terms of your descending efferent fibers, then you've got efferent fibers, you have motor function going to skeletal muscle. So in a disease process which predominantly affects myelin, Your predominant symptom burden will be motor, i.e. weakness, and will be proprioceptive, i.e. ataxia, clumsiness in coordination. We have 1D fibers, and then we have C fibers are the two main others which are clinically relevant in terms of when we're talking about just generalized peripheral neuropathies. So we term them unmyelinated axons. So the 1D actually has a very thin myelin sheath around it, but it's thinly myelinated. It's still a small diameter nerve. And C fibers are unmyelinated. And they are predominantly responsible for perception of pain, perception of temperature. They're a bit slower in terms of their conduction. And you'll probably notice that if you put your hand on something very hot, you have that slight delay for a second where you realize it's actually burning, and you take your hand off them very rapidly when the motor control kicks in. But that's slower action than your motor action. So that again is relevant. So if you've got a classic story would be what fibers are predominantly affected. Unmyelinated would be a disease process which predominantly affects the axon. The axon is most vulnerable at the longest length at its distal end. So a diabetic will get a length-dependent distal, initially sensory process, because it will affect these unmyelinated axons initially because it's axonal. And they often have a loss of pain perception distally or excess pain in the presence of neuropathic pain. And they'll often have altered temperature perception when they put their feet in a bath. So that simplistic kind of example separates that concept we have of a disease which predominantly affects myelinated nerves and versus a disease which predominantly may affect unmyelinated nerve axons. So I'm going to start with a case, and this is a fairly straightforward case. So, and we'll talk through it a little bit because I'm conscious there'll be varying degrees of experience, I think, in this scenario. But so let's start with a fairly typical one. We have a 33-year-old patient who has a viral illness a couple of weeks before admission into hospital. They felt generally unwell. And then they awake 2 days prior to their admission with some new onset back pain, which felt quite muscular in nature, radiating down their legs. And then they develop some generalized neck discomfort. And then they begin to feel unbalanced about 24 hours after that on their feet, especially when they're in the shower, and they start looking at their feet when they're walking. And then when they're admitted, they begin to notice their legs are buckling when they're walking. So it's buckling beneath them when they try and stand. Clumsy hands, struggling to use a phone. And the speech sounds a little bit different to the patient. But they do not have any problems with their vision, and they've not got any problems with their bowel and bladder function. The neurological examination, the general inspection is unremarkable. They have bilateral facial weakness on examination. They're globally areflexic. Sensory examination demonstrates pinprick loss to the knee, vibration loss to the costal margin, and pinprick loss on the soles of the feet. So that is the distribution of the weakness. And you can see that they do have both proximal and distal weakness. There's a predilection for distal weakness, but there's proximal weakness also. So they proceed on to have some investigations. They have a CSF protein, which is 1.5 grams. Normal value is about 0.45. And a white cell count, which is less than 1, but the normal plasma CSF glucose ratio. So I'm going to put my chat on. Does anybody want to volunteer a diagnosis? Good. We've got some GBSs coming through. So GBS is a syndrome. And does anybody want to try and tease out which type of GBS this is? And would they not be confident to do so yet? So good. There's a few words and acronyms coming through here, which GBS often is. So we've got an AMSAN, Fisher syndrome. Any others? Some AIDPs. Okay, cool. That's good. So we're getting that kind of spread of, and this is GBS. And we'll go back and just go through this case in a minute, but just kind of tease out some of that clinical reasoning why. I think it's just an important thing to say. GBS is a description of what was initially described actually in the early 20th century as basically something which was an ascending paralysis, which basically wasn't polio. Okay. And the definition of that not being polio thing was the whole absence of fever and the absence of a cell count which was elevated on CSF examination, especially later on. The neurophysiology around it actually was only kind of more described in the 50s and 60s, actually, around neurophys. So when we talk about Gillen and Barre and someone else, Stroll, who described it all back in the early 20th century, they were describing that ascending paralysis in the absence of a kind of clear infective focus. So you are only describing a syndrome, which potentially has a trigger. Now, people have tried to define it much more closely down now to answer what type of inflammatory reaction it is. But it's a bit of an umbrella term, really, to describe that immune-mediated acute neuropathy, okay, which comes on following post-trigger and often is monophasic in nature. So let's move on, okay? He says, confidently, if you can. Apologies. So they may go on to have some neurophysiology, and I'm going to just briefly comment on this. So in this situation, we've got some changes, and we'd have doing neurophysiology maybe a few days later. And what we see is we'd see some delayed F waves, some prolonged distal motor latencies, temporal dispersion and conduction block. And this is very typical of a primary demyelinating process. So this would suggest that the problem is within myelin sheath. And I'm going to come back to that in a second, but I'm going to skip one of my slides again. And I am just going to flip back in a mo. Just one sec. I've got multiple screens going on here, folks, so it's chaos. So we're dealing here with a disease of the peripheral nervous system. We're not dealing with a central nervous system disorder, okay? And people may remember, and I will flip back to the slides in a minute, this patient had a lot of pain at onset, and they also had quite a bit of proximal weakness at onset too. So the legs were buckling beneath them. On examination, we had grade 4 around the shoulders. We had weakness at the hip flexors as well. So it's important to remember here that and we've got globalized areflexia. So we've got clearly a disease process which is affecting peripheral nerve. We're globally areflexic. It is sensory and motor in nature. It had onset of back pain and neck pain at onset. So to summarize this story, what we've got here is we've got an acute inflammatory demyelinating polyradicular neuropathy. We have an acute history coming on over a few days. It's inflammatory, it's post-viral, and we've not got evidence of an infective process when we've done the CSF initially. It's demyelinating because the neurophysiology has confirmed that process is a demyelinating kind of process on neurophysiology. And it's a polyradicular, multiple radicular neuropathy. Now, the radicular bit is quite important. So that suggests it's nerve root, which is inflamed as well. And we talk about this as neuropathy, but this is something which is not respecting length dependence like we would do in diabetes. You would not get a radiculopathy with a typical long-standing diabetic neuropathy. What you have in GBS is you have inflammation which is affecting both nerve root. You can see this here in your middle diagram. These are your nerve roots. So right next to where the spinal cord is, you're going to have inflammation of this roots here, both sensory and motor fibers. They will be inflamed, and that leads to pain. It leads to radicular pain, which is in the back and radiates down the legs, or in the neck, radiates to the arms. Now, you don't always have that, but the idea that we don't have pain at onset of GBS is not true. And you will often see sometimes cases which are understandably people are worried about something like cauda equina when they first come in, because often have back pain, it's radiating down the legs, and then they've got this ascending weakness. So I'm going to go back a little bit just to look at our history. Okay. So again, we've got typical things here for a GBS injury. We've got a preceding viral infection. Now, the classic description of our infections before GBS are things like Campylobacter infection, diarrheal, but again, they don't have to be. Influenza is a really common reason for people to get GBS. Onset of that infection is, kind of 2 to 4 weeks often prior, sometimes even further back. And then we get the history of the back pain. They felt it was muscular, then neck pain, then unbalanced. And that history of being unbalanced in the shower, again, remember that's strongly suggestive of sensory ataxia syndrome with that proprioceptive loss. Okay, very dependent on that sensory visual input to stabilize balance. And again, that strongly suggests that we're dealing here with something which may be predominantly affecting our myelinated fibers. Legs buckling when they're trying to walk, again, it's strongly suggestive of some kind of proximal weakness, knees or hips, clumsy hands, incoordinated. So the history here isn't that of lots of tingling or lots of numbness, but you can get tingling and numbness, obviously, in GBS. Remember, this is a history of someone who's predominantly complaining of something which is mainly balance and weakness when they present, okay? And other key point here, which comes out in history, is this bilateral facial weakness without any other significant cranial nerve loss in the context of an ascending weakness, strongly suggestive of a GBS syndrome. Elevated CSF protein, which is a key part, and then neurophysiology is not helpful in your acute setting, but in a later setting can help confirm to you whether we're dealing here with something which is predominantly what we term axonal GBS, we'll come back to that in a minute, or your typical AIDP. So in this situation, we're dealing with the most common type of GBS that we get in kind of Western Europe and in the United States, which is AIDP. So there are some guidelines out there, folks, which you can read if you really want to. And this is the EFNS PNS guidance on the GBS. And just to kind of summarize it, they do have some history here. So what the diagnostic criteria are for this. It's a progressive weakness of arms and legs with an absence or decreased deep tendon reflexes in affected limbs, worsening for no more than 4 weeks. So the story cannot be for longer than 4 weeks by definition. What is supportive is relative symmetry, absent or some mild or absent sensory symptoms and signs. Remember what we talked about that. Cranial nerve involvement can be supportive, especially if it's bilateral facial weakness. Autonomic dysfunction, autonomic nervous system dysfunction can be supportive. Respiratory insufficiency due to muscle weakness, obviously, as we talked about, and that muscular radicular pain that people get with a recent history infection. So what we've talked about here is we clearly have the required criteria here, and we obviously have some quite strong supportive criteria as well when they present. And in terms of investigation, we get this abnocytological dissociation, this high protein, normally with a white cell count, which is quite normal. Now, it's important to stress that having a normal protein does not completely exclude that diagnosis. But having a very high protein does. And that's basically because the high protein essentially is related to that proximal disease that we see here, that proximal inflammation. So if your GBS for some reason is mainly got a distal inflammatory picture, then you're not necessarily going to see a high CSF protein. And Evan loves a diagram. I won't go into this in too much detail, but I want you to look here at the AIDP here on the right-hand side. And so what we've got here is and we think this is antibody mediated. We're not entirely sure what all the antibodies are in GBS, and there's quite a lot which is unknown, especially in AIDP. But we get inflammation of the myelin sheath here, and it's normally complement mediated inflammation. Okay, so and this is quite an important graph because it demonstrates a little bit the time course and the timeline of what happens in GBS. So you get your infection, and that's your little blue tick there early in your graph. And then once the infection settles, then you get your formation of antibodies. In this case, in this graph, they've used the anti-ganglioside antibodies, which we'll come back to in a minute. And then once they start to rise, then you start to get your weakness. You get your segmental demyelination, and then you get your weakness. Now, that should not go on for longer than 4 weeks. Normally, you hit the peak of weakness within a couple of weeks. And then it slowly improves over the space of a longer period. And there are different types of GBS. So far left is your classic GBS syndrome. So that could be AIDP, AMAN or AMSAN, which we'll come back to in a bit. But there are other patterns of weakness that people get rather than just the ascending weakness. And there's probably two to point out. One is the Miller-Fisher syndrome here. So Miller-Fisher syndrome is a triad of ataxia, ophthalmoplegia, and areflexia. And actually, it's very much ocular motor structures and some brainstem involvement, but you can get some obviously overlap with neuropathy too. But the eyes are quite striking. They're unsteady. They're often not that weak. Once you see a Miller syndrome, you don't tend to forget them. And pharyngeal cervical-brachial variant essentially cuts out the bulbar function and your upper limbs, and might have a degree of facial weakness with it too. Now, they are strongly associated, these slightly funnier ones, with this GQ1B antibodies, and they are a form of ganglioside antibodies. So you'll often hear neurologists say, send the gangliosides, especially if it's a funny pattern. I'm often was sometimes looking for these different types of funny types of GBS. It's a very good paper, by the way, in Practical Neurology by Benjamin Wakely, if you ever wanted to read it, back in 2015, but it's probably still relevant in some cases. So to summarize, we have GBS, and we have different types of GBS under that umbrella term. Now, when we talk about GBS most of the time, we are talking about AIDP, acute inflammatory demyelinating polyradicular neuropathy, I just mentioned. But there's two other important ones, AMAN and AMSAM. Now, in these scenarios, the onset may be very similar, but in AMAN, we'll often have pure weakness without any sensory. And then when you do the neurophysiology, it'll look very axonal in neurophysiology, so you won't get those typical demyelinating changes suggest that there's slowing of conduction velocity. And in AMSAM, again, it'll be very axonal on neurophysiology. And in that case, there will be sensory and motor. Now, there's probably a slightly different pathological mechanism behind these axonal variants of GBS. And often their recovery can be harder as well. And often they don't make as quite a complete recovery as most AIDP patients do. But there's a lot of commonalities between them. So it can be easy to confuse yourself a bit with the GBS, but just these are really important kind of concepts which kind of link all of these, which is that you have an acute or subacute onset. It's often acute, but you have your peak disability by 4 weeks. There's often a trigger. There's often global areflexia. Ignore that 10% of retained reflexes. There's often areflexia. You have a high CSF protein, and they do eventually show a degree of spontaneous recovery. Okay. I'm going to just flick up the Teams chat just for a second. Are there any questions at that point? Because I've raced through a little bit there before I move on to the next section. I'm going to come back to axonal variants in a bit. So any questions there before I move on? I've not hung around the neurophysiology chat, just I'm conscious of time. So Saad, I'll come to that in a minute, if that's okay. I will explain that in 2 seconds. Okay, if that's okay for a minute, then I will crack on. So Saad's asked how AMSAN is different to AIDP. So in terms of managing GBS, so I think for your grade, I think the important thing for you to remember, and I've not actually put this into the presentation, but I really want to hit home that there is the standard neurological treatment of GBS, but the key management of GBS is how accurately and how well you monitor them and how you manage the complications of immobility. Okay, and I can't stress that enough. So monitoring, we'll come back to that in a minute, but respiratory monitoring is key because they are at risk of neuromuscular respiratory failure and can require intubation. Venous thromboembolism risk is important to manage and optimize as much as possible. The risks around bulbar management and secretions is really key. Optimizing nutrition, and making sure the physios are in place and they're on a proper mattress, etc., around their risk of pressure sores, etc. So these things are super important, and we shouldn't underestimate how important they are. But when it comes to specifically around the inflammatory change which is causing the neuropathy, so first of all, as a concept, if they're very mild, and there are some GBSs which are mild, who are still mobile after 2 weeks, giving them treatment is not going to offer them any benefit. They will spontaneously improve and probably get to the same point with or without treatment. So it's best just leaving them, and they can basically spontaneously remit. However, that general measure about if they're independently mobile doesn't hold true, obviously, if they've got upper limb dysfunction. So if you left that untreated, there's a chance their recovery may not be as complete, in which case then you would want to potentially use some treatment. Ideally, we probably want to treat them early because the inflammatory changes are basically gone within a week to 2 weeks. So if you delay and delay and delay by days and days and days and days, you miss the chance actually to reduce the volume and severity of the inflammatory damage affecting the nerve. So a bit like stroke, but maybe slightly less kind of dependent on minutes, is the concept of time is nerves. You do want to try and treat them as safely but as quickly as you can. Okay. Now, there are two proven treatments basically for GBS, and that is IVIG and plasma exchange, and they were generally equitable in the trials. Now, IVIG is preferred because of its ease of administration compared to plasma exchange, but actually in terms of outcome, there isn't actually a huge difference between the two treatments. There's studies if anyone's interested. And this was Saad's question was about, well, what about axonal GBS? So now I'm going to get a bit neurological now, and I apologize for that. But so as we talk about axonal GBS, that's what it looks like on a nerve test. So in terms of how do you differentiate them? Actually, well, clinically initially, it can be not obvious. It's not obvious to try and differentiate axonal and demyelinating GBS, especially if it's a pure motor variant like AMAN. So this is probably the old model we had of how it worked. We just used to think there was antibodies, and rather than in AIDP, which is over on the left-hand side of your screen here, we used to think there was just segmental demyelination. So it targeted the myelin, and we felt that in acute motor axonal neuropathy or acute motor and sensory axonal neuropathy, the damage was essentially injuring axonal membrane, and that's what we thought was happening. But actually, and therefore, because they get more axonal injury, that doesn't regenerate as well as myelin, therefore they don't do as well. But actually, it's probably a bit more complicated than that. And I'm going to skip this slide to this one. Okay. So the thought process now really is that actually what we've got is we've got an antibody, and these are often strongly associated with these things called ganglioside antibodies, the axonal GBSs. So AMAN is the example here. And we have this GM1 antibody, which is formed as a cross reaction against infection. So you get this cross reactivity, this molecular mimicry, and then the target that they target on the nerve is in this thing called the node aranvier, if anybody remembers that from medical school. So obviously we have our segments of demyelination, and then they kind of form these nodes, and that helps our saltatory conduction along the axon. And what we think is basically we get loads of inflammation at the node, and that basically stops the conduction coming through the axon. And that's the initial thing. It's blocked rather than the axon is damaged. So it looks axonal when you do a neurophysiology test, and then we differentiate it on the neurophysiology from AIDP. But actually, it's just in the inflammation slightly in a different place on the nerve, and we've got a block, we've got a conduction failure, essentially, of the nerve. Ultimately, if that's left untreated, you do get axonal damage, and it does tend to be a bit more severe. So we think it is very relevant. So that's why it differs. The treatment is the same, but the neurophysiology in AMAN and AMSAN looks different. And we think the target of the antibody-mediated complement kind of driven inflammation is a slightly different target. We think the target is the node rather than the myelin segment in between the nodes, which is what's happening in AIDP. So I'm going to mix it up a little bit. Okay. And got the same case, but you do the CSF and you've got this. Okay. So instead of normal white cell, your cells are slightly high. You've got 35 cells and they are predominantly lymphocytes. You still do the neurophysiology after 8 days and you find that you have a demyelinating neuropathy. Sorry. Yeah. Now I'm going to pop the chart up again. And I want someone to tell me, is that still GBS or would you be worried about anything else? And there's no such thing as a stupid answer in this situation, folks. Okay. So anybody got any volunteer, anything, what they think we need to think about in that scenario? Any other thoughts? Okay. People still think it's GBS? Cool. So I'm going to skip you down there. Oh, got a couple of things. A few other things thrown in. Okay. So I'll change the question on what people have these things. I think this is probably still GBS, but what things do you need to be careful that we do not miss? Any volunteers? Well, George has mentioned viral. So infection, number one. Yep. And I'll come back to infection in a minute. non-encephalitis. We'll come back to that in a minute. Thank you, Abdullah. So infection, and I'm going to throw in cancer as well. Okay, good. So, um, so I just showed you obviously the, the current EFNS guidance around GBS, and traditionally we'd always use the CSF, wouldn't we, to kind of say, well, cells are normal, protein's high, picture fits, that's GBS, panic over, let's treat GBS. But if you've got these slightly elevated white cell count, do we need to rethink that formulation? Do we need to think about something different? And to cut it through, essentially, there's been a big study now, and on that big study of 800 patients with GBS, they looked back, and actually 16%, so a considerable number, actually had slightly more than 5 cells on their CSF. So that causes some consternation a bit when you get a slightly high white cell count, but you are allowed a slightly elevated white cell count in GBS if it completely fits. Now, there is a differential diagnosis for people who present with a acute neuropathy who have elevated cells in their CSF. Now, the key thing in this case was that we actually still had clear evidence for demyelinating neuropathy, so that really helps us. But just to kind of say, well, what other things can there be if we've got a high CSF white cell count with a sensory motor kind of process affecting either nerve root or peripheral nerve? So we talked about GBS does it, but just to kind of say, well, you have to think about cancer if the history might fit. So if they're systemically unwell, there's a lot of weight loss. Someone mentioned meningitis there, but if you had that kind of pattern of ascending weakness with lots of pain, but also maybe headache and a cranial nerve palsy, like a third involving the pupil, you'd be worried about something like leptomeningeal mets from a solid organ malignancy, which can pick out nerves moving up and may not be obvious initially on the scans. Hematological malignancy, especially something like lymphoma, you often have you might have generalized lymphadenopathy, but then they can present with an ascending severe neuropathy or polyradiculopathy, which can sometimes mimic and look a bit like GBS. So again, your history of any other disease process in the background is really important. And infection, and the key one actually, even though it's not super common, but is HIV seroconversion can present with a GBS. So that's an important one, just having the back of your mind. And CMV can cause a polyradicular neuropathy, especially in immunosuppressed patients. There's always Lyme disease lingering in the background. So if they have gone somewhere which is endemic in Lyme, or they had a bite just before it came on, you can get a polyradiculopathy, not a polyradicular neuropathy really with Lyme, but a polyradiculopathy. They normally have quite bad cranial nerve involvement, often at onset, and they often have a history of diarrhea and fever as well. So it is something just having the back of your mind if you have a very high cell count, but obviously it can be a little bit overdiagnosed at times as well, Lyme disease. So again, coming back to what are the red flags for our history of GBS? So if we have very striking asymmetrical weakness, which is marked and persistent, people with very severe respiratory failure with very mild or no limb weakness is basically, I've never seen GBS do that ever. Motor neuron disease can do that. Pompe syndrome can do that. Myasthenia gravis can do that at times as well. Very predominant sensory symptoms with mild weakness. You just got most GBS has motor component, really. A very pure sensory syndrome is more likely to possibly be something which is affecting the sensory neuron on its own. So we call that a dorsal root ganglionopathy or a sensory neuronopathy, and that's a slightly different differential diagnosis. We talked about viral processes. We talked about cancer. So again, if this fever or prominent systemic features which are not consistent with GBS, you need to rethink things. Anything which obviously suggests that this is actually a cord lesion, so a sensory level on the trunk, hyperreflexia, bowel and bladder dysfunction. Okay. I'm going to put my chat back up. Why abdominal pain and vomiting? Anyone want to have a guess? Nope. Porphyria. Okay, so porphyria presents often with abdominal pain, vomiting, and an acute neuropathy. Okay, so bear that in mind. Sam, you've asked about leptomeningeal mets lead to radiculopathy. Well, the leptomeninges will still pick out the nerve, essentially. So anything which is meningeal-based disease, it can still pick out your peripheral nerve. You can still pick out the nerve roots. So because it's not, yeah. So you're still picking out those roots as they exit. So and it just essentially just kind of spreads down and out. So okay, nystagmus is obviously suggests a central disease process. Alteration of consciousness often strongly suggests a brainstem disease. Anything which is basically wrong for the time course, anything which is basically longer. Okay. So a few extra things here, which I'm going to come back to in a minute. So how do you predict severe cases? And the key thing about predicting severe cases, and this helps you when you're admitting them, basically. And you can predict who's going to be severe. And it's fairly obvious stuff, which predicts whether it's severe or not. So you get, this is a study essentially which looked at about 350 patients and who basically ended up ventilated. And essentially they figured out a score. And it's fairly obvious, really, determine who is bad. Basically, if you score highly on this EGRIS score, you can predict that they are very strongly likely to need intubation. And basically, you score highly if you come into hospital with a rapid onset of weakness, if you've got a weak face as soon once you come into hospital, and you've got a high MRC, you've got a low MRC sum score, which basically translates into, grade 2 rather than grade 5 power. And if you score high on the EGRIS, you are likely to require intubation, 60 to 90% risk of requiring intubation. So that's a nice thing to have in the back of your mind, that time of onset, if they're rapid onset weakness over the space of 48 hours, and you're seeing them at that 48-hour mark, and they've got facial weakness or their neck's weak or their arms are weak, they're going to need to go to intensive care for monitoring. Now, I have seen some intensive care practitioners historically kind of say, well, you've given them the IVIG now, so that'll sort them out. But clearly that IVIG doesn't work in that way. It doesn't just reverse the process. It helps long-term recovery. So they're still going to go south before they get better. Therefore, it doesn't matter if you give them IVIG, they still need to be monitored in a place or have a controlled intubation if they require it. And if you work in the NCA, that forms part of the suspected neuromuscular respiratory failure guidelines about how you monitor these patients, including FEC monitoring and breath counts. So what if they're not improving? Some of you might work in ICU and you can often get this, you often get the thing, well, they've not improved after, say, a month or 2 months. Well, they've been ventilated for 6 weeks. Basically, they're not getting better. You just need to stop treating them. Are they now essentially ventilator dependent for life? The answer is no. Okay, so this is a study where they looked at them for people who were ventilated for longer than 2 months, people who were ventilated for less than 2 months. And it was very obvious, obviously, the people ventilated for less than 2 months quite quickly over the space of 6 months were independently mobile with no issues at all. The people who were mechanically ventilated often were not walking unaided. They were very disabled at the end of the study point, after 6 months to a year. Now, but you extended that study out and went to a few years down the line, you can see actually a significant majority did get to independently mobilizing. So you really can't see that deficit doesn't help. So that you need to give them longer, essentially, in terms of recovery. So you can't make a judgment if they've been ventilated for 4 weeks that they're never going to walk again. That simply doesn't work. The next key thing is, well, if they're bad and they're not seemingly improving quickly, should they give them more IVIG? And there was a trial done about giving more people more IVIG, and basically it was negative. So, and actually, not only was it negative, it was terminated early because the second IVIG group had more adverse events, serious adverse events, including thrombosis and other things. So it's definitely a no to giving people second dose of IVIG, the Guillain-Barré syndrome. There are potentially new treatments on the horizon, complement inhibitors probably, to be honest, which will help. Doing a trial in GBS is a nightmare. But But there are some initial trials which suggested some hints that there's some improvement, and there are some further phase 3 trials probably on the way. We do need better biomarkers though. So at the moment, we're just completely dependent on our neurological assessment to determine whether we think that disease is under control or whether we think the inflammation has now been treated. We don't have a perfect test. So what we need really is we need a biomarker, something like a CK for muscle. We need something similar for nerve, but not only nerve, we need one for axon degeneration, and we need one for myelin loss. So what would be nice to see in a GBS patient is that after treatment, they're no longer losing any myelin because the myelin biomarkers flattened out to the bottom, and we're not seeing. We've seen axonal peak, but we're not seeing the axonal loss going up. We're seeing it stabilize eventually and then slowly come down to normal. And that will tell us essentially we've got the disease under control. There is likely to be better markers, and there's been some work done on certain biomarkers of axonal damage, but also some other things as well for myelin biomarkers as well. So hopefully that's coming along, and we'll see in the near future. I'll skip that. And mortality is quite low, thankfully, but it's not insignificant. It's around 3%. And again, I reiterated how other things matter. You see, pneumonia is a big cause of death. Cardiac arrest due to autonomic involvement often can be a cause of death. So they often don't die necessarily of the GBS per se, but the complications of the GBS often are the things which leads to their mortality. So I'm conscious I've only got 10 minutes, but I'm just going to skip through this case because I do think it's quite important. So this is a case I looked after as a new consultant. He was very severe. Okay, so he develops a lot of symptoms over about a 4 to 5 week period, so a little bit longer than you'd be comfortable for GBS. And he also had a lot of ophthalmoplegia, a lot of eye movement when he first presented. His pupils were involved as well, which would suggest that it was, almost like intranuclear type affair, which was affecting him. But he had no, it's pupil sparing actually. So no, it wasn't. It was more like a medical third rather than external compressing. And he bilateral facial weakness, fine. He was very, very weak. He ended up in ICU, areflexic. And these were his eyes. He had this quite nasty ptosis, and he had this really nasty third on his left, which again was pupil sparing. And he had loads of tests done, and I won't go through all the tests, but he did have some positive ganglioside antibodies. And his neurophysiology was completely consistent with GBS. So surely home and dry, GBS treats his GBS. So you think that, but he had tons of treatment and got worse, had transient improvements, then got worse again. And basically we were flailing a little bit. So he had one red flag given his progression. But really what he did have is he had something called a pan-neurofascian nodopathy. And the reason why I'm going to bring this up is this is basically a new group of conditions which are GBS-like, but is slightly different. So I mentioned this thing called the nodoramvia before, but there's not only one target in that, there's probably multiple targets that inflammation can target in the node. And the key thing about these conditions is, and these are the neurofascian different nodal antibody targets that we have, is that they can be very severe. They can end up on your intensive care unit. They can be associated with some renal involvement often, a bit of nephrotic syndrome, and they have a high mortality rate. And not only that, they respond beautifully to rituximab, but not in any way to IVIG. So, pardon me. So they're actually quite important. And I've talked about ganglioside antibodies before, and you'll often be asked about checking the ganglioside antibodies and making sure it's done. And we talked about IVIG and how it's important to give that early. But if you've got a patient who's not improving or is atypical, ganglioside antibodies doesn't change management in any way, shape, or form, whereas these antibodies do. And importantly, they're very difficult to interpret if they're done after you've given someone IVIG. So actually, for your stage of training, the awareness of checking a immunology sample or storing an immunology sample to make sure we've got enough to go back and test this if required in the future is hugely important. Okay. So it is important that we have that in our minds in terms of these are a slightly different group of inflammatory neuropathies away from those GBS syndromes I just mentioned. So I talked about how some other red flags, some additional red flags, I believe that they're important. So these things kind of tie into here, really. You had unexplained renal dysfunction in this patient, which we didn't have a good explanation for, and he didn't have vasculitis. We've had, if you have someone who has marrow dysfunction, you need to think about hematological disorders, some with a very high cell count. But in this case, again, we had someone who had some red flags, which are a hint, but it's important just to bear in mind, well, if we're going to treat GBS, do I need to make sure I store a sample if we need to go back and reinvestigate this patient more effectively? That's really important. So as I said, everyone tells you to check ganglioside antibodies in patients with GBS, but actually it's probably more important to check these antibodies than it is to check gangliosides because they actually do change our management. Right, I'm going to check the chat just for a second. Any questions at this point before I move on? I've got my chat back up. GBS patients should always have an LP prior to treatment. Yes. Because again, if you do a LP after treatment, you can have an artificially high white cell count caused by the IVIG. The nodal antibodies, that's something you can do in any hospital. It's only done in Oxford, but in a way, Becky, you don't really need to check it per se. It's more important that you store a sample. And often if you just do, for example, an immunology or an electrophoresis sample before or send off something to be stored at minus 70, if there's a way you can store a sample in your lab blood sample, then you've done the job. Even if you do send the ganglioside antibodies, then at least the sample often is there in the lab, which then we can go back and test. If you do send it in Salford, for example, you can order it online. Bolton, you can order it online. If you can't know another hospital, send it on a paper form, say it's nodal antibodies to send to Oxford. They'll figure it out. There's loads of people doing it now. So, Julian, is there any ways to otherwise differentiate AIDP versus acute onset CIDP in the acute phase of the presentation? Yes, there are. There's been a study done to look at the two and how they differ in terms of their clinical presentation. So, it's not a big study, and there's not a lot of numbers in each wing, but the acute onset CIDPs are not as severe, number one. So they don't tend to get any cranial nerve involvement. They tend to mainly be restricted to lower limbs and mild involvement of upper limbs. So facial weakness doesn't tend to occur. Respiratory failure doesn't occur. The tempo tends to be a little slower. So it tends to be kind of like 3 to 4 or 2 to 3 week of onset rather than over a few days. And then obviously there is a response and then a relapse. But other than that, there isn't a perfect way to differentiate those two cases initially when they're coming through the door, because you don't know basically if you're dealing with very early GBS or are you dealing with acute onset CIDP. The only brilliant way of knowing that is time. What's more difficult is something called a treatment-related fluctuation, which is what you're allowed to have in GBS. So there's some patients who come in with GBS, they're treated within about 4 or 5 days. They have the treatment, they bounce up a little bit, and then they dip down again, because basically the inflammatory process is still ongoing. And people get very excited that that might mean it's CIDP because you're getting this fluctuation. Is it therefore relapse remitting problem? But it's not. You're just getting this transient change in the clinical condition because you're giving them some IVIG. They're often still GBS. So, but if you get someone who had treatment, improved for 6 weeks, and then deteriorated, now that is likely to be either SIDP or CIDP, which again would be treated with a slightly more longer course of IVIG over the space of a few months before you stop them and see then if the disease goes into remission. Becky, if we have GBS, should we try and transfer this patient to Salford at all? So the current structure is that if it's bound or GBS, they're on IVIG, treatment's been done, they're going to improve, that's great. You also don't want to be transferring patients who are at risk of respiratory failure willy-nilly. So you need to often have the period of monitoring, and doing a hospital transfer is often not 100% safe. Our ICU also probably would have a meltdown if we transferred all GBS patients, because we'd have 8 or 9 or 10 beds on our ICU completely riddled with GBS patients who don't move. So I think they are at the moment reluctant that we basically take them all across. And we probably also need a slightly more robust out of hours neurology service if we're going to do that as well. So we don't have a neurology SHO overnight, for example. We have no on-site neurologist on site. So at the moment, GBS, because it is tends to be regarded as a slightly more straightforward presentation, treated to given IVIG, they're seen and then they improve. At the moment, they are kept in their local hospitals to do that. And then we take the ones which maybe aren't behaving like GBS, essentially, or we're worried maybe something different. We tend to transfer them over. In the perfect world, we take them all, obviously. But at the moment, the structures aren't there to do that. Any other questions? Cool. Okay. Stephen, numbers, risk of patients who receive IVIG goes thrombotic event. I did know this acutely. There's been a study done in long-term IVIG use, and you only need, this number needed to harm is 7. So the risk is higher than you think with IVIG and thrombotic risk, because it is hyperviscous. So I can't say off the top of my head what the risk is acutely, though, off the top of my head. Cool. I actually think that's half past, and I think that's probably a reasonably nice place to stop. I'm just going to show you a couple more slides, actually. Just going to briefly tell you this one. So this is just to reiterate that obviously you can get GBS-like syndromes with ICI, with immune checkpoint inhibitors. Now, actually, probably it's slightly different from your standard GBS if you're interested, because they do get a lot more early axonal, and they tend to get, there's been a few pathological cases which presented biopsies where you get much more prominent lymphocyte inflammation affecting the actual nerve itself and not just the nerve, the myelin sheath, which is different again even from AMAN. So it's more of a neuritis in addition to kind of more classic GBS-like scenario. So in that is the scenario, and I've only briefly mentioned this before, is that we do not give steroids in GBS because the early studies suggested that the mortality was higher in patients with GBS who got steroids. Now that's probably not the most robust data in the world, but no one's been brave enough essentially to repeat that study. So at the moment, the standard treatment choice is IVIG plus plasma exchange. Now, however, if you get a GBS syndrome or like syndrome triggered by immune checkpoint inhibitors, there is a role for steroids, which is different from your standard GBS care. So I tend to use pretty massive doses of steroid in these cases, especially if I think that they're quite severe and they've only had a partial or non-existent IVIG response. And the likelihood is that these cases are going to become more frequent. So peripheral nerve toxicity does occur with them, and often in combination therapy, often it's a bit more severe. So obviously, the neurological complications of ICI inhibitors tends to be more severe in terms of the recovery from it is less complete, and it can significantly affect their ability to go on and have further treatment for their underlying malignancy. So though they are rarer complications of ICIs, they're often quite more devastating. So it's it's that. So just a brief comment about ICI-induced GBS-like syndromes. That's the one scenario where we do give steroids to treat them. So the complication before the nodopathy, the reason why he got more than one IVIG was because his time course appeared to be progressing beyond the 4 weeks. So essentially, he was treated as from GBS into a form of a severe chronic inflammatory neuropathy, which we didn't have a clear explanation for why. And he continued to show these very transient treatment responses to treatment, a bit more than treatment-related fluctuation because he was way further down the line. So that's rationale for continuing to treat him because he was always a bit atypical. And it was the right decision because ultimately he didn't have a classic a classic GBS, and he did have this nodopathy, which ultimately responded to rituximab. So these days the journey won't be that long, but at that point in 2018, well, only one antibody had been described at that point in time. So this case was a slightly different antibody target. So actually had not even yet been reported in the literature. So it was very novel at the time. It's not that novel now. We see it all the time. Right, I'm going to stop there if that's okay. I hope that wasn't too obscure. Fingers crossed it was at least relatively useful. Any questions before I leave you to your lunch? No, good. Okay, that's yeah. We're getting some teaching off some proper doctors this afternoon, so fingers crossed that'll be better than that. Okay, and I hope you have a nice lunch. Okay, thank you.
Cheers, Tim. Okay, so we're going to take a quick half an hour break now. Feel free to stick around in the meeting if you want to, but just make sure you join back around 1 o'clock. And then the next few talks will start. And then there'll be a quick comfort break at around 3:30. So it's a bit of a stint, but you'll get some really good talks out of it. Cheers, everyone.
Hi everyone. I think, shall we get going? I think you've all just had an hour for lunch. I'm Katie. I'm a neurology research fellow. And I've been asked to talk to you for a whole hour about myasthenia. So let me just get the slides back up, sorry. Right. Could someone unmute and just tell me that they can hear me and see the slides?
Yeah, you can see it.
Yes, we can.
Yeah, I can hear you and see it. Do you want to try to just change the slide first?
Yeah, is that the
Yeah,
move
works
to the
well.
disclosures? Brilliant, excellent. Right. Always just horrible talking to a completely silent screen. So fab. Right. So yeah, so I've been working in the myasthenia clinic for 4 years or so now, and I'll be due to CCT in a month's time, and hopefully continue to work in the myasthenia clinic at Salford. I've done a PhD relating to myasthenia in various bits of research. So we'll start with a case. 67-year-old gentleman who is usually fit and well, and he goes to the emergency department complaining of double vision. So when someone comes in with a neurological problem, we want to go back to basics, and these are things we learnt in medical school. We want to ask about the onset. When did it start and how did it start? Was it sudden? Did it come on gradually? Over how long? Has it come and gone? Is there fluctuation to the symptoms? Is there a fatigability to the symptoms, and are there anything associated? So this is really this will help you get the diagnosis of myasthenia, basically, in that sometimes the onset can be quite sudden, in that when it's affecting the eye muscles, you have to have a certain level of weakness before then you get double vision, and then the patient notices they've got double vision. So at some point they will notice they've got double vision. But the main thing is that there is a fluctuation to it, and usually there's a worsening. So they kind of have it's coming and going, and then it's gradually getting worse over a few weeks because it's an inflammatory disorder. And there's this fatigability, so it's usually worse in an evening. And most neuromuscular diseases, patients feel worse in an evening. We all feel a bit worse in an evening, but there is this particular thing with the more I use my muscles, the weaker they become, and if I stop and rest them, they can get better, and then they get worse again. And then we're going to ask about other things. So in myasthenia, I just tend to work through where the muscles can be affected. So have they got double vision? Have they got droopy eyelids? Have they got problems with their chewing, their speaking, their swallowing? Have they got problems with their breathing? Have they got problems keeping their head up? And have they got proximal arm and leg weakness? And then you're going to move on to examining the eyes. So when we're examining the eyes, now why is that not quite showing at the bottom? You all know how to look for sixth nerve palsy anyway. So when we're examining the eyes, start in the primary position and get them to focus on your finger and have a good look. Do the eyes look symmetrical in primary position? And ask the patient, do you have any double vision in primary position before you get moving? And then, so normally you should be able to look one way and the other, and the eyes will move smoothly together and they won't get double vision. Things that we're going to try and look for when we're examining patients for double vision are third, fourth, and sixth nerve palsies. Because if you can identify specifically a unilateral third, fourth, or sixth, then it's more likely to be that. So with a third, we know the eye is down and out with a ptosis, plus or minus pupil involvement. The pupil might be large. With a fourth, the problem is with so if you try and look when you're looking in primary position, the affected eye will be up, it will be higher, and then if you try and look over to the right, the eye will look over to the right but will be up. So the problem patients have with the fourth is in looking down, so they'll often describe difficulties with double vision going downstairs because they can't really look downwards without getting really severe double vision. And then with the sixth, that's probably the most common sort of nerve palsy that we'll see causing double vision. You know that the eye doesn't go outwards. So if you've got a left sixth, if you try and look to the left, the eye doesn't fully abduct, and therefore you get double vision when you go that way. And sometimes in myasthenia, you can get a sort of false one of these. It can look a bit like one of these nerve palsies, but things will change. And the key with myasthenia is that the eye movement abnormalities are fatigable. So if you hold that position or you make them repeat it several times, it will get worse. And more commonly than not in myasthenia, it just doesn't fit one of these patterns. It's just complicated. They look one way, the eye's doing one thing, you look the other way, the eye's doing another weird thing, you look upwards, they're starting to drift apart as well. And so you can just then term that a complex ophthalmoplegia. And if it's fatigable, it's a fatigable complex ophthalmoplegia. And then you can pretty much diagnose myasthenia. So is it fatigable? Is there ptosis? So ptosis is where there's drooping of the eyelids, and is the ptosis fatigable? So again, after you've looked at the eye movements, you're going to keep the eye movements looking up for a good 45 seconds to a minute. And you want to look at the eyelids and see where they are in relation to the pupil. And you want to see over time, is that eyelid moving down towards the pupil to suggest a fatigable ptosis? And there's this thing called the ice pack test, and I'm not sure this video is going to play, but it doesn't really matter because basically all you do is you put some ice on the eyelid. So if you have a patient with a ptosis and you think it might be myasthenia, but there's nothing else to suggest it, so the eye movements are normal, you're not quite sure if there's a fatigability, if you put an ice cube sort of wrapped up on the eyelid for about 2 minutes and then take it off, in myasthenia, that ptosis will improve and you'll just quite obviously see the eyelid lift up. So it's quite a nice, easy trick to do if you've got a sort of isolated ptosis that you think might be, because generally myasthenia is bilateral, but it's often asymmetrical. So sometimes they do come just with one eyelid drooping. So this case one, we check is acetylcholine receptor antibodies. They're the most common antibody in myasthenia and they're positive. And so we diagnose them with ocular myasthenia gravis. And so the initial treatment we'll use is pyridostigmine. The brand name is Mestinon, and they come in 60 milligram tablets. So a sort of standard dose is 60 milligrams 3 times a day or 4 times a day. Some people will struggle with side effects of pyridostigmine, particularly muscle cramping and diarrhea. And so either we need to use lower doses, so sometimes we'll cut the tablets in half and tell them to take 30 milligrams regularly, or you add in propanthyline bromide to try and counteract the side effects. So, we all know about myasthenia, it's affecting neuromuscular junction transmission. So the nerve releases acetylcholine, which goes to the acetylcholine receptors, seen here in green on the postsynaptic membrane. And the problem here is that you're getting antibodies to that acetylcholine receptor. And they block the receptor, so they stop it from detecting acetylcholine. They also internalize the receptors, you've got less receptors there. And they also activate complement, and you get complement-mediated damage at the postsynaptic thing as well. So AChR are the most common antibody type, but the second most common antibody type is MuSK. So MuSK is a protein that helps with AChR clustering. So the receptors don't just sort of sit in, regular patterns along the membrane. They tend to cluster at the top of the folds, and MuSK is needed to enable it to do that. So if you lose your MuSK, the AChR receptor is just going to scatter, and you lose that transmission. Now MuSK is more common in those from Asia, and it tends to be more predominantly bulbar. You can't necessarily always tell the difference between someone with AChR and MuSK. So we generally, as an approach, if we think someone's got myasthenia, we'll test for AChR. If it's negative, test for MuSK. There's also this LRP4. You can get antibodies to LRP4, which is sort of similar protein to MuSK. And then you've got this proportion of patients who are called seronegative patients. And about a third to a half of patients who are previously classed seronegative actually do have antibodies if you test for them in a different way. So most labs will test for AChR antibodies using an ELISA or an RIA, but you can send blood down to Oxford for a low affinity or clustered assay, which is done on a cell-based assay. So they grow cells and they cluster the AChR receptors on the cells, and then they see if the antibodies bind, because some of the antibodies only bind if those AChR antibodies are clustered together rather than just being able to bind to a receptor. And the main difference really is that the MuSK antibodies don't activate complement, which probably doesn't mean a huge difference now, but in the future that probably will change how we treat the different conditions. The other thing with MuSK antibodies is that they are IgG4, and therefore they're more likely to respond to rituximab as opposed to AChR. With AChR myasthenia, we do tend to split it into 3 subtypes. So you've got this early onset in the females in their 20s and 30s who have thymic hyperplasia. So if you scan the thymus, it's often enlarged, and histologically, if you take the thymus out, you can see this thymic hyperplasia, a sort of lymph node type formation there. So that's why you mainly see females in their 20s and 30s with myasthenia, but then you get this second wave in the 60s and 70s tends to be males, which is late onset myasthenia. So roughly over the age of 50 we'd label as late onset. Do get females in there as well, but tends to be more males, and it's actually rising in older males as well. And then 10% have a thymoma. So 10% is paraneoplastic being produced from a thymoma. So everyone gets a CT thorax to make sure we're not missing that. So we've got the problem in the thymus. So in early onset, there's this hyperplasia. Late onset, there's atrophy. And we all get atrophy in our thymus as we grow older, but there's thought to possibly be this sort of specific loss of immune tolerance in late onset myasthenia, or it's not completely proven. And then 10% with a thymoma. But all of these lead to these T and B cells, which produce pathogenic antibodies, the AChR receptor antibodies, which cause the blocking of the receptor, internalization and activation of complement. And that all leads to this fatigable muscle weakness. So we can do, as well as antibody tests, we mentioned that there'll be certain patients who are seronegative. We might therefore want to do neurophysiology. And the 2 main things to ask for if you're asking for neurophysiology is repetitive nerve stimulation and a single fiber EMG. So with neurophysiology, we've got nerve conduction studies, which is where they'll sort of stimulate a nerve and see the conduction along it. And if you ask specifically, they can do repetitive nerve stimulation, where they repetitively stimulate one of the nerves. And in myasthenia, you'll get this decrements. This is normal here. Hopefully you can see my cursor. And then on the right, there's this decrement. The amplitude comes down as you repetitively stimulate that nerve. Now, if that's not completely clear, they might move on to do a single fiber EMG, and they won't always do this because it takes about an hour. It's quite fiddly. And so they'll only, the neurophysiology consultant will only do this if you specifically say, I would like single fiber EMG, or if you say, I really want to know if this is myasthenia or not, or a neuromuscular junction condition or not. And you'll see jitter. So they isolate this single muscle fiber, and you see this sort of difference in the response. This is normal, and then this is jitter. And so if you see, they'll do several different muscle fibers, and if you see jitter on a number of those, then you can say there's a problem with neuromuscular junction transmission. The key point about this is that you can get false negative results if they're on pyridostig mean. So ideally, unless they're in crisis, you want to stop the pyridostig mean 48, 72 hours before the neurophysiology test to kind of get the most out of it. Right, another case. Case 2, 23-year-old female. She's usually fit and well, and she presents with a 3-week history of slurred speech, difficulty chewing and swallowing, and she's got some proximal limb weakness. So the key in the history is this fatigability. And when we examine her, start at the eyes. We're looking for ptosis and ophthalmoplegia. We're looking at eye closure. So often it can affect the facial muscles and they get difficulties closing their eyes. You might need to ask about getting shampoo in the eyes, about difficulties with smiling, problems with the speech. So it's a bulbar dysarthria that they get, not a pseudobulbar, which would suggest an upper motor neuron problem. And we'll come back to that in a moment. Is the neck flexion weak? So I don't quite know why, but in myasthenia, you often get a discrepancy between neck flexion and neck extension. And so do test the neck flexion by asking them to push forwards onto your hand. or rise their head off the bed if they lay flat. A fatigable shoulder abduction weakness. So you want to test for shoulder abduction strength as normal in both sides. And then I get them to move their arm up and down at least 10 times to exercise that shoulder abduction movement, and then test it. I usually do that just on one side and then test it again on both sides so that you can feel the difference in the side that has exercised. And the side that has exercised will now feel weaker than it was before and weaker than the side that has not exercised. And that once you've got that, you know you've got a neuromuscular junction problem, because no other cause of weakness will do that. You can also sometimes see elbow extension and finger flexion weakness in myasthenia. It's not quite as common, but you can get more distal weakness. But in the legs, it tends to be hip flexion weakness. So again, you want to test hip flexion and then see if it's fatigable. So get them to exercise that hip flexion, maybe move it up and down 5 times, and then test it again and see if it's weaker. So this lady, I just want you to really have a listen to her dysarthria. Let's see if I can skip it forward a bit. No, we'll just have to listen to the preamble for a minute. But already looking at her, you can see maybe the eyelids are a little bit lower, but I don't know, maybe she's just got too much makeup on. But the mouth doesn't look quite right, does it? In a minute she'll start talking, and you want you to have a listen to the voice. Oops, sorry. I was trying to. There we go. I don't really want to listen.
We actually can't hear her.
Oh, you can't hear her. Oh, hang on a minute. Let me just sorry, because we've got a whole hour. I'm going to do this. I'm going to stop sharing and reshare again with sound. Because I think having listened to the difference between bulbar and pseudobulbar dysarthria is quite useful. A sec. With a pseudobulbar dysarthria, which we'll see with a upper motor neuron problem, for example, motor neuron disease or a brainstem lesion, then you will get this hot potato speech where they talk like, because their tongue is paralyzed, hong. We call that hot potato, as if you've just got a hot potato in your mouth. Whereas with this bulbar dysarthria that this lady's got, it's more of a nasal speech. You can hear her voice sounds very nasal, doesn't it? Well, hopefully you'll hear now. Let's try this. Can you hear me now?
Breathing.
Yes, now we can.
Breathing. Okay, so as you can see, as Lara starts to talk, it becomes far more difficult. This is about as bad as her symptoms have got. With a
around here. Then it's my tongue, which affects my pronunciation. So it can be difficult to talk. This in turn affects my swallowing. So liquid goes up my nose, and it's quite hard to swallow. Then obviously I get the neck weakness around here, and it can affect my
So she's fatiguing as she's talking. Her voice is getting worse. So you can hear this kind of nasal speech, the bulbar dysarthria, and she's explaining that she's got weakness of the facial muscles, which she's aware of. And that can affect the speech as well. So it's not just a bulbar dysarthria. They also have problems with the speech because the lips are weak as well. And then difficulty in moving the tongue. So patients will often describe that they're biting their tongue accidentally. Difficulty choking on food, and drink. And she said their liquids will come back out her nose, and that's often a key symptom I'll ask about, because it kind of helps differentiate between neuromuscular problems with swallowing, and structural problems with swallowing. It seems if there's a lot of neuromuscular weakness, you often get nasal regurgitation of liquids. And then she's saying she gets neck flexion weakness as well.
Breathing.
Oh, hang on.
Breathing.
Try and move on. So when we're examining, obviously we're going to look for the things we've mentioned, but we also want to think about the alternatives. So you want to think about an alternative diagnosis if there are sensory signs. In a neuromuscular junction problem, there will be no sensory signs, so there should be no numbness anywhere. Patients sometimes mention numbness because they're struggling to describe their symptoms. For example, the inability to move their lips, often people will talk about as numbness because they think of it when you get numbed at the dentist and you can't move your mouth. But actually, when you examine the patient, they should still be able to feel everything normally. Tone should be normal. So if the tone is increased, you want to think more about an upper motor neuron problem. So if there's something going on in the brain, the brainstem, you could potentially also get eye movement abnormalities, ptosis, limb weakness. If you've lost reflexes or got brisk reflexes, then you would think about an alternative, because in myasthenia, they should be normal. It is slightly different in Lambertitum, which we'll come on to. But generally, if you've lost the reflexes, you want to think about a nerve problem, and if there's brisk reflexes, an upper motor neuron. Or if there's a sort of other specific pattern of weakness. So, for example, there are muscular dystrophies that have quite specific patterns of weakness. So you can get oculopharyngeal muscular dystrophy can affect the eyes, the sort of proximal limb muscles, and the swallowing. So you can see has a similar pattern. But hopefully you'll get in the history that this is more of a progressive, non-variable illness. But I think it is tricky, sometimes with this fatigability element. You have to kind of take a patient's word for it. And as I said, everyone feels a bit worse towards the end of the day. But this might be a differential diagnosis. This is just another specific pattern of weakness. If you've got weakness of finger flexors and the quads, then this is inclusion body myositis, but it wouldn't tend to affect up here. And I thought, given we've got a whole hour, and I don't think anyone's talking about muscle disorders today, I'd just touch upon other muscle disorders to think about when you see someone with weakness. So I think it's probably, because there's so many, it's best to just think of it in four main categories. So could they have a genetic disorder like we were just talking about, a muscular dystrophy? With genetic disorders, you might have a family history. They've probably got quite a long progressive history. So the main ones would be muscular dystrophies, for example, myotonic dystrophy 1 and 2, which have some quite specific features. So myotonic dystrophy 1, you'll have the typical face with frontal balding, thinning of the face, long, thin face, temporal wasting. There's Duchenne and Becker muscular dystrophy, which are the boys with big calves. Limb girdle, facioscapulohumeral and oculopharyngeal muscular dystrophy, you just kind of get from the pattern of weakness and the kind of progressive history. There's glycogen storage disorders, McArdle's and Pompe, which can be quite tricky. McArdle's is the one where you get this second wind phenomenon, where they're struggling to walk as they start going, and then after a period of time, maybe 5 minutes, then get the second wind where they can walk much more easily. There's fatty acid oxidation defects, which I don't think you need to know much about. Channelopathies are worth knowing because occasionally you'll see periodic paralysis coming with a low or high potassium and unable to move, and then they can move once that's corrected. And myotonia, paramyotonia congenita, worth trying to just have a think about that. If you've got a muscle weakness, you're not sure what's going on, have a think about, is there any myotonia? Hand grip myotonia, if you get them to clasp their hand and release it, does it release normally? Is there any eyelid myotonia? Get them to squeeze their eyes shut and then open them and see if they have difficulty opening their eyes again. Although interestingly, occasionally that can happen in myasthenia. And mitochondrial disorders often come with a raft of other clues to mitochondrial disorder, for example, diabetes, deafness, short stature, and family history. Then you've got your idiopathic inflammatory myopathies. So dermatomyositis, hopefully you'll notice the rash, the heliotrope rash or the Gottron's papules. Then there's antisynthetase syndrome, where you get mechanic hands and interstitial lung disease along with a myositis. Necrotizing myopathy, we see really severe proximal weakness with a very high CK, which are associated with either these SRP antibodies, which you get as a paraneoplastic thing, or HMG-CR antibodies, which you get with statins. So it's important to think about these in patients presenting with sort of subacute onset proximal limb weakness. Always worth checking SEK. Just to make sure it's not more of a muscle problem than a neuromuscular junction problem. And then inclusion body myositis gets lumped in with the inflammatory myopathies because it's thought to start off as inflammatory, but then it quite quickly turns into more of a degenerative process. And as we mentioned earlier, they've got this long finger flexor and quadriceps weakness, which is a chronic history. Then you've got metabolic and endocrine things which can affect the muscles, so hypokalemia, magnesemia, and hypothyroidism, and toxic steroids and statins. So, I mean, my suggestion to you guys would be is if someone's got muscle weakness and you're not quite sure if it's muscle or neuromuscular junction, worth checking a CK. If the CK is up, and it's a sort of acute-ish history, you think it might be inflammatory, then there's a myositis panel you can send, but you also need to send these separately. The HMG-CR antibodies are not on the myositis panel, so you do need to send those as well, particularly if they've recently started statins. Okay, so this lady, we've diagnosed her with myasthenia. How are we going to treat her? So originally, the guy with ocular myasthenia was given some pyridostigmine. Pyridostigmine is an acetylcholinesterase inhibitor. Acetylcholinesterase breaks down acetylcholine. So if we inhibit the acetylcholinesterase, we stop the breakdown of acetylcholine and we have more of it around at the neuromuscular junction. So that works in a smallish proportion of, well, it works in patients, but it's obviously, for most patients, it's not enough. For most patients, we need to do something else. So in a crisis, we tend to try and get rid of the antibodies that are circulating by using IVIG or plasma exchange. So these can work relatively quickly, but only last about 4 weeks. So they're not an ideal long-term solution, and they come with risks. So IVIG comes with a risk of thrombosis, and plasma exchange needs a central line in most places. So we tend to reserve this for crisis mostly. Usually, if pyridostigmine is not working, we then move on to corticosteroids, prednisolone, to dampen the immune responses. And the concern in myasthenia with steroids is this risk of a steroid dip. So it's thought that if you give high-dose steroids to myasthenia, a proportion of them will get dramatically worse as you start high-dose steroids, have this steroid dip. And so because of that, we tend to start low and build the dose up. And that seems to reduce the risk of that from happening. And it has the added benefit that we don't know what dose people need. And so some people get away with only escalating to a lowish dose when they improve. Of course, for those that need a high dose, it takes a while to get to the high dose, and that can be an issue. For those with early onset myasthenia, and actually those all the way up to 65 now, there is evidence for thymectomy. So for those under 65 with AChR antibody positive myasthenia, we should think about doing a thymectomy quite early on in the illness. Want to stabilize them in their initial illness, but then to try and avoid long-term immunosuppression, we will then usually try and get them a thymectomy, which can be done keyhole, a VATS thymectomy, which has been shown in a randomized controlled trial to reduce the long-term steroid and immunosuppression requirements. If they're too old or don't want a thymectomy, or we've done that and they're still requiring high-dose steroids to keep things under control, then we'll then move on to using a long-term immunosuppressive drug. So azathioprine is the only one that's licensed, but we are increasingly using more mycophenolate, methotrexate, maybe calciurin inhibitors. to try and keep things under control. And then currently in the UK, we use for refractory disease, if these haven't worked, rituximab, so B-cell depletion with an anti-CD20 rituximab. And so this is the current guidelines, which were written in 2015 by John Sussman, but these are being rewritten at the moment, and so there's going to be new guidelines out next year sometime, I believe. So the current guidelines are available on the Association of British Neurologists website and Practical Neurology, and on the MyAware website. So MyAware is the charity for people with myasthenia in the UK, and they've got the management guidelines and various other bits of information for different people. So it's worth knowing about this and directing patients to it, as well as consulting it yourself. And in the guidelines, it talks about how to escalate pyridostigmine doses, how to escalate prednisolone doses, how to de-escalate doses as well, and what to do if someone gets admitted to ITU. The other really useful page on the MyAware website is the drugs to avoid. So there are certain medications in myasthenia that can make things worse, and in particular certain antibiotics. So, no one needs to memorize these. We just need to know they're there. And if you're prescribing any new medication for myasthenic, we should just double check that this isn't a drug known to worsen myasthenia. Now, sometimes we do need to use medications that are known to potentially worsen myasthenia. And I think there's a spectrum. So, in general, if we can avoid the antibiotics, we do. If we can't, we can't, and we try and we just keep an eye on them. Beta blockers are meant to be contraindicated in myasthenia, but we have a lot of patients on them who are absolutely fine. So again, it's just a case of being aware and monitoring the patients. There's a lot of antipsychotics that we need to be careful of. And most recently, there's been a HMRA thing about statins, but our approach is that most people are absolutely fine with statins. Statins are important. Try them. If the myasthenia gets worse, then fine, stop them. The only other thing I think on the MyAware website is a bit of information. They do have a support officer if they're questioning about benefits and things like that you can direct them to. And there's a bit of information about the DVLA. It is a notifiable disease to the DVLA, so they do need to let them know, but most commonly they can still continue to drive. Okay, but suddenly the drug companies have taken an interest in myasthenia, and over the last 5 years has just been an explosion of clinical trials, and so it's all going to change. Hasn't quite just yet in the UK, but in America it has. So the two main categories that they're now using in America are complement inhibitors and FcRn inhibitors. So the neonatal Fc receptor mediates IgG recycling. So you recycle, your body is constantly recycling its own IgG. And so if you stop that process from happening, then your IgG levels come down. And because these are IgG autoantibodies, these levels will come down, and autoimmune disease is mediated by an IgG autoantibody will improve. So there's a few of these. Efgartigimod was sort of the first one. Rosie's not far behind, and then these other two are probably coming shortly afterwards. So efgartigimod has been available on an early access scheme in the UK. We're awaiting very shortly a NICE decision about whether, we've been waiting for about 2 years, but I think it will come soon, a decision about these, and I think they'll be reserved for refractory disease because they're very, very expensive, but they are being quite widely used in America. And the other category is complement inhibitors, and particularly C5 inhibitors, zilucoplan, ravulizumab, eculizumab. All three of these are being used in the States. We do not have the second two, but zilucoplan is being assessed by NICE at the moment, and there are several other complement inhibitor therapies under study. Also, the big category really is B-cell depletion. So we currently use CD20 depletion, but there's other types of B-cell depletion being trialed, other ways to modulate T and B cells, and some other interesting things. And perhaps most interestingly, target specific. So there is a trial for MuSK-CAR-T, which will specifically deplete MuSK-positive B cells, which is quite exciting. So watch this space; it's all going to change. I've told you all of that. Okay, let's move on to another case. So case 3 is a 64-year-old gentleman. He's known already to have ocular myasthenia and he's on pyridostigmine 60 milligrams TDS, and he's been all right. He's had it for about a year or two. He was doing quite well. But over the last few days, he started to notice problems with his swallowing. His speech has become slurred, and he's now starting to feel a bit breathless. So when you examine him, he's got bilateral fatigable ptosis, he's got a bulbar dysarthria, he's drooling, he's got neck flexion weakness, and he's got shoulder abduction and hip flexion weakness, 4 out of 5, which is fatigable. His SATs are 99% on air, his chest is clear, his ABG is normal, his forced vital capacity is 1.4 litres, and his breath count is 14. He's a 70 kilogram man. What do we do next? Does anyone want to unmute and suggest something we could do? Go back, because we always forget what the actual history was when someone asks that question. 64, he's on his pyridostigmine already, but a few days he can't swallow, he's breathless, he's clearly generalizing, he's got weakness everywhere, and this is his FVC. Are people happy with that? No, don't know. I would call ITU. I'm quite worried about this because patients with neuromuscular respiratory failure will go off before their SATs and their blood gas go off. So we need to monitor the forced vital capacity, maybe the breath count if you really can't get a spirometer, but the breath count's not very accurate. It's the FVC that will help guide you when someone needs to go to ITU. And in a myasthenic crisis, they go downhill quite quickly. And this chap's clearly gone downhill quite quickly over the last few days. And any treatment that we can instigate at this point is going to take a few days to work. So he is going to get worse before he gets better. And when we're monitoring the FVC, we get worried once the FVC gets worse than, so if he, in a 70 kilogram man, 1.4 litres would be about the cutoff that I'd be worried. So kind of about 2 times the patient's weight. Did someone put a hand up then? Do you want to mute and talk if you can? No?
Hi, yeah. Sorry, just a really quick one.
Go on.
So I've worked in like, a few different hospitals where like I've seen my senior patients come onto like the acute take, and then you do the breath count and it's poor, and then you sort of contact various people on ITU and stuff, and they all sort of they all say there's no way of they don't have a way of checking the FVC. So I know you're saying like breath count's not particularly reliable. Is there anything else that you can do if there's no way of checking the FVC to kind of measure the severity?
Well, so I mean, not really to check the FVC. So the breath count probably is the best equivalent we've got in terms of that. But there are other things that would make you call ITU, I suppose. So the drooling worries me. So sometimes patients should be intubated purely because they can't manage their own secretions anymore. If they're not managing to swallow their own saliva, then they need intubating. If you can see that they're tiring, sometimes the FVC is sort of just about managing, but you can see that they're just really struggling with their breathing and they're feeling tired, then they should go. And really, because these patients ideally should have a nice controlled intubation before they have a respiratory arrest. And I think we're lucky that I mostly see these patients in Salford, and I think the ITU there are quite happy now when we say, look, this patient we're really concerned about, they'll tend to come down. But I think there are other hospitals where you do have to fight for the patient and say, no, I don't want you to wait till the blood gas has gone off. I don't want you to wait till they're desaturating, because that will be too late. I think it's keeping an eye on those sort of things. Ideally the FVC, if not the breath count. Can they manage their respiratory secretions? Are they just looking tired and they are going to fatigue? They're going to get worse the more they do, and that's perhaps when you might call. Does that make sense?
Yeah, that makes sense. Thank you.
So yeah, so if we get anyone with acute neuromuscular disease, myasthenia or Guillain-Barré is the other most common one. We want to be monitoring the respiratory function. So a 4-hourly forced vital capacity. If you can't find a spirometer, then the breath count. If you can do the breath count, try and standardize it by making them count at 2 beats per second. So you can get a metronome on your phone and set it to 2 counts per second. And you want them to try and keep in time to that so that you know that that's as standardized as it can get. We are trying to gather data about how reliable this is, and I think generally it is. But for example, the other day I saw someone in A&E and her breath count was only 8, and I was really worried. And then when I found the spirometer from the ward, her FVC actually was 2 liters. So and she's been fine actually. We got her to the ward, started her on some steroids, and she's done okay. So it certainly isn't completely accurate, especially if they've got dysarthria as well, because they will really struggle with the counting because of that. Make sure that when they come in, you've talked to them about ceiling of care and documented that, because once they're tiring, they're struggling to speak, they're struggling to breathe, it's going to be much harder to talk to the patient about that. And unfortunately, we're seeing increasing numbers of older people with this condition, and it may be that although this is a reversible condition, they're going to really struggle on ITU. For the most part, I would really encourage everyone to be for full escalation because it's reversible. But clearly, someone who's already very old and very frail is going to do poorly if they have to be intubated. Now, this really is just broadly about neuromuscular disease. So really more in Guillain-Barré syndrome, we want to think about autonomic disturbance. So asking about autonomic symptoms, doing a lying standing blood pressure, making sure you've got an ECG, just thinking about other things that could go wrong. Making sure they've got DVT prophylaxis is essential in anyone who is weaker than they usually are because they're extremely high risk of VTE. Thinking about the swallow and making sure the swallow is safe. Often patients have been muddling along at home for a while and probably with a lot of aspiration and need a good salt and dietitian input, and often will need an NG tube whilst they're in. We've even had a couple of patients who've needed a PEG for a few months whilst they get better. And then some physio and OT to keep them moving whilst they're in. And make sure they're not on any contraindicated medications. When do we want to go to ITU? So if we're particularly concerned if there's prominent bulbar symptoms and they're rapidly getting worse. So we're going to call ITU if the FVC is less than 20 mils per kilogram body weight. So in a 70 kilogram man, that's less than 1.4 litres, or roughly equivalent to a breath count of 14. Or if it's falling, and this is perhaps more important in that if they come in and the first day they're at 2 litres, 2 litres, 2 litres, and then it's 1.5 litres, I'd be much more worried than the person that comes in at 1.5 and sticks at 1.5 for a little while. Or if they're tiring, not managing secretions, like we were just saying, it might not necessarily be all about the FVC. Sometimes you can just see a patient is tiring. And you just don't think they're going to be able to keep going whilst we can get the treatment going. We don't wait for the rise in CO2 or the acidosis. So if they do get intubated, once they're intubated, we tend to stop the parodisticmine because it causes a lot of secretions, and that can be an issue when someone's intubated. So we tend to just stop it, and we go for IV high-dose methylprednisolone because it doesn't really matter if they have a steroid dip once they're on a ventilator. They can just get through that on the ventilator and then improve. We avoid the contraindicated drugs, and the one to remind ITU about is magnesium. I don't know why ITU like giving out magnesium a lot. And we use a rescue therapy, so either IVIG or plasma exchange. And there's probably no difference in efficacy between the two treatments for myasthenia. They both involve giving blood products, so it is worth, I think it's worth checking HIV, hepatitis B and C before they have these treatments. And in general, a sort of general statement of any neurological disease, it's worth sending off antibody tests before they have IVIG. So the AChR antibodies, or in Guillain-Barré syndrome, the ganglioside antibodies, or sometimes we've got loads of other weird and wonderful antibodies we want to send off. Try and get those sent off before they have the IVIG because you can get false positives after they've had that. We don't always give IVIG or plasma exchange in, acute neuromuscular weakness. So, in a milder myasthenic crisis or a milder GBS, it's not necessarily always needed. I mentioned the lady who came to A&E the other day. We've decided just to start with steroids and see how things go. Takes weeks to work, probably days to weeks. IVIG probably at least 3 or 4 days before you're going to start seeing an improvement, and even then it's going to be a mild, slow build up over a couple of weeks before you get the maximum efficacy. As I said earlier, IVIG and plasma exchange probably have equal efficacy but different risks. And there's no evidence for repeat treatment in Guillain-Barré. So in Guillain-Barré, there's no evidence to repeat it. In myasthenia, what we're supposed to do is use the lower dose, 1 gram per kilogram IVIG, and then reassess and give another gram per kilogram if we feel it's necessary. I think generally, if someone's so severe, they've got really severe bulbar weakness, they're on ITU, then 2 grams per kilogram is necessary. But sometimes we do go for the lower dose in patients who are sort of managing on the ward. So the other thing to check before immunoglobulins will be serum immunoglobulins, because those who have a low IgA are at risk of an anaphylactoid reaction to the IVIG. When I think about the thrombosis risk, that's a big issue with IVIG, is the risk of clots. So DVTs, PEs, heart attacks, strokes. So have a look at the vascular risk factors. If they've got loads of vascular risk factors, we really want to try and avoid IVIG if we can. There is a risk of just general allergy, and so the nurses must be following the guidance on how to start the infusion slowly and then up titrate the rate over time. Generally with the IVIG, you do need approval, but in an acute situation for acute myasthenic crisis, then that's okay. But for longer term treatment, we'd need to go to a panel and have it approved. So 0.4 milligrams per kilogram per day is the 2 grams per kilogram, split over 5 days, or it'd be 0.2 for the 1 gram per kilogram. And I think it's important to consent a patient. Probably we don't always get written consent, but you must have mentioned to the patient the thrombosis risk and have documented that you have told the patient about this, because if they have a big heart attack, and sometimes they do, you need to make sure you've got documentation that the patient was aware that could have happened. Or plasma exchange. So unfortunately, the machine we've got at Salford, we need a central line. There are other places in the country who have machines that you can do it peripherally, and we're hoping to get one of those at some point. And that's what limits us really in neurology, is the access to people who can do central lines. This may change as neurology trainees become dual accredited and medicine trained as well. I don't know whether people will be able to keep up their skills in doing central lines. But also we rely a little bit on the renal nursing staff to help us with the plasma exchange. The staff on the ward, if you've got a patient who's having plasma exchange, and you're sort of one of the doctors on the ward, it might be your role to prescribe and order the albumin. But generally, the nurses who are going to do the plasma exchange will tell you how much they need and how much needs prescribing. Okay, let's move on to another case. Oh, we've only got 10 minutes left. 73-year-old man. He's got metastatic melanoma. He's had ipilimumab and nivolumab treatment 3 weeks ago. Planned to be curative. So this is quite specific because this is a real case. He came feeling generally unwell. He was found to be bradycardic with a heart rate of 20. He was in complete heart block and he had a troponin of more than 6,000. So he had a pacemaker put in. And then after that, he started to get some double vision and a left ptosis. His CK was 2014. So hopefully most of you will recognise that this is checkpoint inhibitor-associated myasthenia, myositis, myocarditis overlap syndrome, which is the sort of most common neurological complication of checkpoint inhibitors. And this guy, he was given IVMP and then high-dose steroids, rituximab, IVIG, 2 grams per kilogram, mycophenolate, abatacept, which is an anti-CTLA-4, because one of his checkpoint inhibitors was targeting CTLA-4, so they thought they might as well try it. Pyridostigmine, this was all at the Christie, but he wasn't getting better, so he came over to Salford. And when he arrived, he had marked ptosis, double vision, bulbar dysarthria, fatigable speech, facial weakness, couldn't really seal on the spirometer. That is one of the problems, you know, in us telling you, please do a FVC, is if the patient's got such facial weakness, sometimes they can't actually get their lips to seal on the spirometer. His FVC had been 3 litres 10 days ago, and now it was 1.4. So that big drop is very worrying. His single breath count was 7. But he was maintaining his saturations. He was generally weak. And we realised that he was too unwell really to conduct a full examination. So ITU came down and took him to ITU and intubated him. And he had further plasma exchange, more rituximab. He had a tracheostomy, multiple complications. And then, you know, a few weeks down the line, we find he's got this complete ophthalmoparesis, complete ptosis. He's areflexic, 3 out of 5 in the arms, 0 out of 5 power in the legs. And unfortunately, because of all of these complications, a decision was made to withdraw treatment and he died. So this checkpoint inhibitor toxicity is really severe. So you're blocking the immune checkpoints, either CTLA4, PD1 or PDL1 to get this T-cell attack of the cancer. But you often get autoimmune side effects. In neurological complications, the mortality is really high. So in the initial case series of immune checkpoint related myasthenia, the mortality is sort of 30 to 50%. We found more recently by being really aggressive with treatment, the mortality probably is lower than that if you recognise the symptoms really early and really aggressively treat them. So you'll note we did give him IV methylprednisolone from the outset. You know, this isn't just myasthenia, you've got the myocarditis and the myositis to treat as well. And actually, there's thoughts from some people that maybe it's not as straightforward as we thought, and actually perhaps the eye signs are a myositis of the ocular muscles and myasthenia is less of the issue. But these patients need recognising, highlighting urgently and treating aggressively. But the other thing this chap had, you'll note he had absent reflexes and quite prominent leg weakness. He probably had a critical illness neuromyopathy. So this often complicates patients who've been on ITU for a while. They have atrophy of the muscle fibers, loss of axons, and those that get critical illness neuromyopathy do worse. So the mortality, you know, is variable, but it says between 16 and 55%. 20% have some ongoing weakness or sensory change once they go home, the ones that survive. It's worse if there's nerve involvement, not just muscle involvement. And so it's important to try and mobilise our patients on ITU early, if possible. Right, do we have time? Just about, yeah. So case 5 is a 55-year-old man, fit and well, smokes 10 a day. He's complaining of proximal limb weakness and he's got a dry mouth as well. So he's got no ptosis, no double vision, no dysarthria, difficulty chewing or swallowing, so no bulbar dysfunction. But he does have this fatigable proximal arm and leg weakness. His reflexes are initially absent and then become present with exercise. His sensation is normal. So hopefully you've all decided that he has Lambert-Eaton myasthenic syndrome. So we'll just go back. So proximal fatigable limb weakness, reflexes are absent, but with exercise they become present. And autonomic dysfunction as well suggests Lambert-Eaton. It's not always as clear-cut as that. It often looks just a bit like myasthenia, but think myasthenia with autonomic symptoms. And then if you want to be fancy, try and find the absent reflexes that become present with exercise. In reality, that's difficult because we've taught you to do the power before you do the reflexes. You've already exercised the limbs before you've checked the reflexes. So often we don't really find this unless we go back and look for it later. So autonomic symptoms such as a dry mouth, erectile dysfunction. Most commonly, you've got these voltage-gated calcium channel antibodies, and 50% are paraneoplastic from a small cell lung cancer. So this guy's a smoker. And the difference in the neurophysiology we saw earlier with repetitive nerve stimulation, you got a decrement in myasthenia. You get an increment with Lambert-Eaton myasthenic syndrome. So you again will ask for repetitive nerve stimulation, but the neurophysiologist will tell you actually there was an increment and that suggests Lambert-Eaton. And the treatment, if there's a tumour, is to remove the tumour. Otherwise, we just treat it pretty much the same as we treat myasthenia. Case 6 is a 41-year-old gentleman, generally fit and well. He's previously had a right arm amputation a month ago because of a wound infection when he was in a road traffic accident in Jordan. Again, weirdly specific because this was a real case. He went to a DGH with 2 weeks fluctuating diplopia and swallowing difficulty. He was found to be in type 2 respiratory failure, so he was intubated and then transferred to us. On examination, he had bilateral ptosis. His right eye was sort of down and out. He was complaining of double vision. He had bilateral facial weakness, struggling with his swallow, weakness in 4 limbs, which was worse proximally, and fatigued with repetition, neck flexion weakness, but reflexes were normal, sensation was normal, there was no ataxia. He was intubated and ventilated. Few crackles at his left base. Everything else looked all right. His wound looked all right. So we weren't quite sure what this was when he first came in. So when we've got something that's coming on subacutely, we think inflammatory or infective. And we weren't sure if it was neuromuscular junction problem because of the fatigability. So if it's inflammatory neuromuscular junction, we're thinking myasthenia or LEMS. If it's infective neuromuscular junction, botulism. Is this a brainstem problem? So inflammatory brainstem problems can cause eye signs and limb weakness. So Bickerstaff's, demyelination or sarcoid, or an infective brainstem thing. So listeria tends to go for the brainstem, or TB. Or was it a nerve problem? So inflammatory nerve problem with eye signs, Miller-Fisher syndrome or Miller-Fisher variant of GBS, or an infective nerve problem that might cause these symptoms. West Nile can cause a flaccid paralysis. So we didn't know. So we thought, well, we won't make sure he doesn't come to harm. He had an NG tube, he had VT prophylaxis. So we made sure he didn't die from us, not caring for him. We did some investigations. His neurophysiology wasn't clear. His AChR antibodies were negative. He had an MRI head scan with contrast, which was normal. His CSF showed some raised white cell counts, but he just had some IVIG, which can do that. So we weren't quite sure if that was relevant or not. We sent off botulism toxin A, which is a test for botulism. And we treated him. So we tried some powder-stigmine. Well, we weren't sure about starting some powder-stigmine. It can be useful if it gets better to suggest it's definitely a neuromuscular junction problem, but he was intubated and we didn't want to cause loads of secretions, and we wanted to get neurophysiology. So I think we held it for a while till we got the neurophysiology and then gave him a little bit. But then by that time, it's unclear if it's been helpful or not because he was intubated. Steroids, again, I think when he wasn't intubated, he started low, building up, but once he was intubated, went for the high dose. Gave him some IVIG to treat for the autoimmune differential diagnoses, and gave him antibiotics to cover botulism and his chest infection. And in the end, it was botulism. His botulism toxin A was positive, which has probably come from this wound from the road traffic accident in Jordan, and he gradually got better. So with botulism, they just get better on their own. And 2 months later, he went home back to baseline, and he was fine. Obviously, you've got to get them through that acute illness where they can develop respiratory failure, but after that, they tend to get better. So it's generally recognised in acute descending paralysis starting in the face with dry mouth, dilated pupils, postural hypertension and ileus. And you get it from either from wounds, or the other one is canned food, canned meats you can get it from. Right, we're running out of time. Should we skip that one? I was going to just briefly talk about congenital myasthenia, really. I think it's just worth knowing there are congenital myasthenias, and they tend to present in childhood and progress over time, and often they're quite disabled by adulthood. They can often only take a few steps. They may have respiratory failure that needs non-invasive ventilation. And we treat them with slightly different treatments. So things like 3,4-DAP, sometimes salbutamol tablets can all help with this kind of keeping the structure together of the neuromuscular junction. But it's quite specialist, and you're going to obviously refer to a specialist. I think the key is thinking about it if you've got someone that you're not quite sure what's going on. Right, so summary. Myasthenia, you get a peak in females in the about 25, peak in males about 65, comes from pathology in the thymus, get bulbar weakness, which can lead to respiratory failure, limb girdle pattern of weakness, asymmetrical ptosis, treat it with powder-stigmine, then maybe steroids, then maybe azathioprine, rescue treatment with Plex or IVIG, and nerve conduction studies show a decrement. 85% are ACHR. The second most common is MuSK. Lambert-Eaton is the one where you get autonomic dysfunction as well, and 50% have a small cell lung cancer, and you get increment on the repetitive nerve stimulation. And botulism, you have this descending weakness. It's really rare. You're very unlikely to come across botulism. So main thing is to prevent harm. Think about VTE prophylaxis. Think about respiratory monitoring as well as you can do it, and appropriate escalation if you are at all concerned about their respiratory function. Checking their swallow and involving salt if it is not safe. Consider the relevant investigations that we've discussed, and please phone us and ask us if you're not sure how to treat them, or if you're going to treat them at all, really, let us know. Any questions? Right, there's a question in the chat. I might have missed something, but why is magnesium contraindicated even if they're low magnesium? We had a patient with low magnesium and fast AF on ICU recently, and nobody mentioned not giving magnesium. He got quite a bit. I don't know why magnesium makes things worse, but it's just known to worsen myasthenia. I think if they had low magnesium, then and then a reason why you should replace it, then fine. You might want to give it a bit slower and keep an eye on their myasthenia. If they're on ITU anyway, then the main concern in the crisis is avoiding them being intubated if they're on that kind of precipice. So I don't quite know why, but it just is known to worsen things. Any other questions? Oh, sorry, you were chatting here. I couldn't see the chat earlier. What is the long-term prognosis in early type myasthenia? It's really variable. So you have some patients that do really well, and go complete remission, and then there's a proportion, and the literature varies a lot, but maybe 10% have kind of refractory disease where they have ongoing symptoms despite all of our current treatments. But in general, people seem to be at their worst in the first 2 or 3 years. So often they'll start with the ocular, get generalized in the first year or two, and tend to be at their worst in the first 2 or 3 years, and then they'll plateau and stabilize at sort of the level that they've got to. In terms of life expectancy, in general, most people don't die from myasthenia. It's quite rare to die from myasthenia these days. Yeah, someone's mentioning it might be the magnesium stabilizing effect on the fast-acting sodium channels. Do patients of previous thymoma have risk of myasthenia later in life? Sometimes we do see myasthenia coming a couple of years after thymoma, but I've never really seen it a delayed thing many, many years afterwards. So certainly we do see patients with a thymoma with positive ACHR antibodies, and they're sometimes referred to our clinic, but if they're asymptomatic, we sort of reassure them and just safety net them. But I think it's usually around the time or within a couple of years of the thymoma. Why doesn't it affect distal muscles but affect facial? Who knows? We don't know. We don't know why people get different phenotypes. We think it affects the ocular muscles more because the sort of difference in their structure, kind of less complex folding. But it is unclear as to why. If we could answer that, we might be able to help get better treatments. Is it all forms of magnesium that can precipitate myasthenia crisis or just IV? I mean, in general, I try and avoid magnesium, but if they need it, then orally it'll probably be safer than an IV. I think, I think because this is a rare condition, generally evidence is scanty for everything. So everything is all a little bit on anecdote and, small case reports and things. So I think it's tricky to be certain for a lot of these things. Are there any particular patients who need seeing in a myasthenia clinic as opposed just to general neurology? So most myasthenia can be managed in a general neurology clinic. In general, they're referred to the specialist clinic if they fail on azathioprine. If they need mycophenolate or methotrexate or rituximab, they usually would get referred to us. Occasionally, I'll pick up sort of the ones that come in with acute crashing bulbar failure because I do a ward round. and see them acutely and then just say I'll follow them up. But our general stance is that the consultant neurologist will refer to us if they've been trying to manage them sort of with the initial steps and the patient's got ongoing symptoms. Fab. Who's due to talk next? It's Monty, isn't it? Is he here?
So I think, yeah, I'm here. So we can change over.
Sorry. Okay, great. Right, thanks very much, everyone.
Right, so I think it's me. Hopefully everyone can hear me. So I'm going to do two talks, one after the other, I think, maybe with a little bit of a break in the middle. So first of all, going to do Parkinson's disease. So I'm just going to share my screen and then find Parkinson's talk, and hopefully it starts okay. So I don't know if I can see the chat, but can everyone just see the first slide here and can hear me? Just someone post in the chat that's okay, or if you can't hear me. Good. Actually, I've just thought, so I'm going to stop sharing for a sec. I'm going to share again, but I'm going to include sound. Forgot to do that because I think some of the videos have got sound. So yeah, we can still hear me, still see me. Okay, good. So can you see the slides now or not?
Yeah, you can see the slides.
Yeah, someone's just posted can't see slides, but you can. Good. Okay, fine. Right, so I'm going to talk about Parkinson's disease. So obviously it's quite something you see quite commonly. And what I'm going to do is, first of all, just show you a few videos, just so that we all understand all the clinical signs that we're looking for, and then just present a few kind of simple cases. Well, just kind of cases that kind of, I suppose, cover most of the things that you would see if you were looking after these people, on medical ward rounds and things like that. Good. So first thing to say is that we don't need to use, a lot of people think that you need to do scans and all sorts of stuff if you're going to make any kind of neurological diagnosis, but we don't need to do any test really to diagnose Parkinson's disease. And we really just diagnose it based on the story and based on the features on clinical exam. Let's get rid of this here. And in terms of what we are looking for, the symptoms that people would present with, obviously, from the story, they might talk about tremor, they might talk about stiffness, things like frozen shoulder and so on. They might talk about difficulty with fine finger movements. So that might be things like doing up buttons, using cutlery, shaving, putting on makeup, that type of thing. And then when we examine them, we're looking for three main clinical signs, which is resting tremor, rigidity, and bradykinesia. So let me just show you some videos of all of that, just so that we're all on the same page before we start talking about cases. So when I look for resting tremor, I usually get the patient to sort of distract them so that just to get them to focus on something else. Hold on a second, let me just get them to focus on something else, so that it kind of brings out the tremor. And I tend to get them to do something like months of the year backwards. And so this chap that we're seeing in the video is telling me the months of the year backwards, and we can see him with a resting tremor. When I'm giving this talk face to face, I usually pick out someone in the audience and get them to do something like serial sevens or something, just to show that it is a little bit stressful. But I think it's going to be a bit tricky to do it over Teams. So here's a chap. He's doing the months of the year backwards. You may be able to hear, and he's got a resting tremor in his left arm.
August, July.
Can you put your arms straight out in front of you now? Straight out in front of you. That's good. And what we see when we put our arms out in front is that the tremor goes away. It's not a postural tremor. It's just a resting tremor. And also when we get them to do actions, it's important to do rest, posture, and action. Actions such as writing, actions such as pouring water between cups. We don't get any tremor. So it's purely a resting tremor. Can people just tell me, is the sound working on the video for you guys? Maybe just someone post in the chat if it is. It's not that important for this guy, but for some of the later videos, so it might be useful. Okay, that's good. So that's resting tremor. We've got to distinguish that from essential tremor. So a lot of people get referred to us diagnosed as a query Parkinson's, where actually we're dealing with essential tremor. Essential tremor is the opposite. They don't have so much of a rest tremor, but they do have a postural tremor, and they do have an action tremor. And it's particularly at the action tremor that's important. So this kind of pouring water between cuts is a really useful sort of way to distinguish between a Parkinson's tremor and an essential tremor. Parkinson's, you don't tend to get much tremor there, and essential tremor is much worse there. So let's have a look at this chap here. It's not a massively great quality video, but I think it does illustrate the point. So
In front of you?
not much rest tremor, a bit of postural tremor, well, significant postural tremor really.
Okay, now up under your nose.
But
Okay,
mostly
so
when we do the cups thing, he really struggles.
Okay.
So this is essential tremor, really not difficult to distinguish this from the Parkinson's tremor. If you just do think of tremor in the 3 stages, rest tremor, postural tremor, and an action tremor when they're doing stuff, it's pretty easy. Often called, some people call this benign essential tremor, but you can see from the video it's not necessarily benign if you can't really do anything with your hands. And the second clinical sign after resting tremor in Parkinson's is rigidity, and we check that just by moving the joint through the full range of movements. You can do that at the wrist joint, and then you do it at the elbow joint. And we're feeling for a kind of stiffness all the way through the movement. Some people talk about lead pipe as if you're like bending a lead pipe and it's stiff all the way through and it's stiff all the way back. We don't really like these terms like lead pipe and cogwheel. We don't really use them anymore, but you may have heard them, so just worth mentioning. And if you're not quite sure about whether someone's got rigidity or not, it's often good to get them to move the other arm. In neurology, we have to have fancy words for everything so that people don't understand what we're saying. So rather than saying the rigidity was more obvious when moving the other arm, we say the rigidity was more obvious with contralateral synkinesis. It's just a fancy way of saying moving the other arm. So here we can see me testing rigidity in somebody, first of all at the wrist, then at the elbow, going the whole way through the movement. I'm not totally sure if he's got rigidity or not, but you get to move the other arm and it's a lot stiffer when we do that. And it's quite, people with Parkinson's, it really does get very stiff when you move the other arm. So that can be just a useful way to bring out rigidity. So the third sign in Parkinson's, and the most important of the 3, the kind of holy trinity, the most important one is bradykinesia. So bradykinesia loosely translates as slowness of movement. And you get them to tap their fingers up and down. I don't know whether you guys can see me or not, but because I can't see myself, but tapping fingers up and down like so. And what we're looking for is not just whether the movement's slow. There's lots of things that might make the movement slow. For example, if the patient's depressed, if they've got cerebral vascular disease or orthopedic problems, they might be quite slow with the movement. But we're also looking for what we call fatiguing, which means the movement starts off big and gets smaller over time. And it starts off kind of fast and gets slower over time. And eventually the movement breaks down completely. So that's the term bradykinesia. That's what we mean when we describe bradykinesia. Oop. Let me get that video back again. So this left hand is pretty good, pretty fast, pretty big the whole time. So not a great deal of bradykinesia. You have to test for quite a long time, at least 10 taps, maybe longer. You don't just do 2 or 3 taps. On the right side, we're seeing probably okay to start with, but then as we kind of go on for a bit longer, it gets smaller, it gets slower, and it almost breaks down completely. So that towards the end of that movement, and see how you need to do it for quite a long time. You can't just do 2 or 3 taps. You keep going for a while, and bradykinesia becomes more obvious. So that's the most important clinical sign in Parkinson's disease. And when somebody first presents with Parkinson's in the early stages, they usually don't have much in the way of gait problems. Usually starts in the upper limbs or in the limbs generally, and they have, tremor, rigidity, bradykinesia, and the gait problems come quite a lot later. If you see gait problems very early in the condition, it may not be Parkinson's itself. It may be things like cerebral vascular disease, hydrocephalus, quite a lot of things can cause what looks like a Parkinsonian gait problem, but without Parkinsonian signs in the limbs. Does anybody know what the earliest clinical sign that we would see in gait in Parkinson's disease? Maybe post that in the chat. You might have had a clue with the video click forward. Do you guys know what sign? You don't get too many gait problems early, but there's one thing that you look for which can help to nail the diagnosis if you're not sure. Yeah, so some people are getting it, some people not. So in Parkinson's, in the early stages, they don't tend to have much of a shuffling gait or difficulty with turning, but the thing they do have is a reduced arm swing on one side. So if you see someone, they've not got a tremor, not everybody with Parkinson's has a tremor, they've got slight rigidity, but you're not sure about it. You think they've possibly got bradykinesia, but you're not sure. Then sometimes just watching them walk and looking at the arm swing can be what clinches. And you need a good amount of room. You know, this is actually quite a big clinic room that we're in here. But if you weren't in the big clinic room, you need to get them outside. You can't just, you know, a kind of 1 foot by 1 foot clinic room that some of us do clinics in Salford. You're not going to really be able to watch the gait properly. But this room's quite big, and we can see quite clearly that his right arm is swinging well and his left arm is not swinging. And if you look closely, you can see he's got a bit of a resting tremor in his left arm. But otherwise, gait's normal. He doesn't have any hesitancy or shuffling or freezing or anything like that. His gait's pretty good, apart from the fact that he doesn't swing one arm. So that would be what you'd see in the early stages of Parkinson's. And if you have had Parkinson's for a while, in kind of more later stage, that's when the main kind of gait problems happen. Yeah, someone's put something about Putin walks that way. There is quite a lot of talk amongst neurologists about whether Putin might have Parkinson's or not. But anyway, let's not go there right now. This is somebody with a much more severe, even though this is a young chap, he's got a much more severe Parkinsonian gait disorder. So let's look for all the clinical signs that we see in Parkinsonian gait. Starts off, I won't start the video yet, I'll just talk through it before we start. So the first thing is he has difficulty standing up. We can't just say that in neurology because people might understand what we meant. So we have to use kind of fancy terminology. So we talk about a rising impairment, but it basically means difficulty standing up. And once he's standing, his posture is quite stooped, and he takes little short shuffling steps. And then when he walks, when he goes to turn round, you'll see he takes a lot of steps to turn round. Normally you take 1, 2, at the most 3 steps to turn round, but he takes a lot of steps to turn round. We call that turning on block. And then he walks back to the seat again with the short shuffling steps. And you'll see as he comes towards the seat on his way back, he speeds up as he goes along and almost falls into the seat. And that speeding up is called festination. So let's look at all of that. So first of all, difficulty standing up. Like I say, we call that a rising impairment. And now he's up, but he's quite stooped in posture. He takes little short steps. He's not swinging his arms. He's got a tremor, right more than left.
And now, and turn round again.
He takes lots of steps to turn round, so he's turning on block. And as he comes towards the seat on the way back, you'll see he kind of speeds up and almost falls into the seat. So that's what we call festination, is central gravity is too far forward. Other features you might look for are things like freezing, when they walk through doorways and things like that. But that's the main sort of clinical signs that we see in the later stages of Parkinson's disease. So that's the main videos that I wanted to show you, just to get the kind of clinical signs out of the way. And now I'm just going to present a few cases just to kind of deal with the kind of spectrum of the types of Parkinson's cases that you kind of deal with as a kind of physician. So case one, it's quite a simple case, basically a 56-year-old chap, and he has slowed down over the last year. Family come with him, they were worried that he's been slowing down. He's got some problems with things like writing and cutlery, so some problems with fine finger movements. And you examine him like we've seen on the video, and you find that he's got resting tremor, he's got rigidity, and he's got bradykinesia. So quite a simple case. How are people going to manage this chat? What are we going to do? Maybe put in the chat just kind of suggestions of how we're going to manage this guy. I mean, I think so someone says first need to confirm the diagnosis. You've examined him and he's got tremor, rigidity, bradykinesia, and he's got that typical story. He's got Parkinson's disease. That's all we do. There's no tests, there's no scans, there's no DAT scans. We don't do anything else. Someone said, assess which symptoms are most distressing for the patient. I mean, his family are worried about him. He's had difficulty with problems with writing, cutlery. So these symptoms are, I think, troublesome. Well, we can ask, but I think they are troublesome. So there's a variety of suggestions. Most people saying dopamine, so most people saying levodopa, and some people saying dopamine agonist to begin with. I think generally, I don't want to spend an hour talking about whether we should start with levodopa or whether we should start with dopamine agonists, but I think the jury is no longer out on that, and the vast majority of people would start with levodopa. In the early trials that they did in the kind of late 90s, early 2000s, there was some suggestion that if you start with dopamine agonists first and then you go on to levodopa, that you might have a sort of delay motor complications like fluctuations and dyskinesia, but there's loads of evidence now just showing that it makes very little difference to delay that, because it works out the same in the end. Levodopa is a much more effective anti-Parkinsonian agent than dopamine agonists. It's much less side effects as well. And if you look at quality of life, for example, there was a big study looking at quality of life, whether you started levodopa or whether you tried to spare levodopa with something else. And levodopa gives much better quality of life. And so I don't really think the jury's out anymore. There are some kind of older physicians who haven't kept up to date, if you like, that think about starting dopamine agonists, but we don't do that anymore. The vast majority of PD specialists start levodopa. You might ask the question, are they bad enough to start medication? Which obviously, we always have a chat to the patient about whether they want to start medication or not. But it is worth pointing out that there has been a study looking at people with early mild Parkinson's who didn't necessarily feel they needed to start levodopa. They were not that bothered by their symptoms, but nonetheless, they were randomized to either start medication or delay medication. And it was quite clear in terms of functioning and in terms of quality of life that if you started levodopa quickly, you did much better than if you delayed it. So there's very few reasons really to delay levodopa in somebody who's sitting in front of you, who's got symptoms which have been bad enough to reach the clinic in the hospital. There's very little reason why you wouldn't start levodopa. If it was any family member of mine, I'd want them to be started on levodopa immediately, basically. So normally, just to keep things simple, I normally use cocarodopa. The cobenodopa and cocarodopa are the same, like Coke and Pepsi. They're very similar. These drugs, the main ingredient is levodopa. Levodopa gets into the brain, gets converted into dopamine, replaces the dopamine that they've lost. But if you just took levodopa on its own, it would get chewed up in the blood, it wouldn't get into the brain properly. So we give levodopa with an enzyme, a drug which blocks the conversion blocks the metabolism of levodopa. And if there's one called carbidopa, and cocarodopa is levodopa and carbidopa, and madapar or cobenodopa is levodopa and benserazide. It's basically just it's just something to help the levodopa get into the brain. Somebody's asked about what you do on acute take. I'll talk about that in a sec. So just to finish what we said, we normally start at 62.5 milligrams 3 times per day, increase up to 125 milligrams 3 times per day after a couple of weeks. We usually take the drug at meal times. It doesn't have to be taken with food. Generally speaking, it is a little bit less likely to cause nausea and dizziness if it's taken after food, but it works a little bit better if it's taken without food. And so there's kind of pros and cons of whether you take it with or without food. Apart from nausea and dizziness, which are usually quite mild and usually settle, the other side effect to be aware of is impulse control disorder. People start gambling, hypersexuality, compulsive shopping. It sounds almost comical, but in my practice, because I deal with a lot of Parkinson's, I've seen people spend hundreds of thousands of pounds lost on gambling, buying hundreds of thousands of pounds worth of watches, having kind of extramarital affairs, 80-year-old woman going to try and find prostitutes, this type of thing. So impulse control disorder can be quite bad, and it's actually much more common with dopamine agonists, which is one of the reasons why we use a lot less of them. It's very rare on levodopa, but it does happen, and it's important just to kind of make them aware that this is a rare side effect. As far as what to do, somebody posted a question about if you're on acute take and you see someone with Parkinson's, should you start immediately or refer to a specialist? I mean, the NICE guidelines suggest to refer to a specialist untreated. The main reason for that is that these medications work so well that when you start coca-L-dopa, often the symptoms can melt away completely. So by the time the specialist sees them, they have no clinical signs. And then if you're going to be looking after somebody for the next kind of, 10, 20 years, you want to just be completely sure that the diagnosis is correct. You examine somebody, they've got no Parkinsonian signs, but they're on coca-L-dopa 125 TDS. You're not sure whether that means they don't have Parkinson's, the diagnosis was wrong, or whether that means they do have Parkinson's, but the medications work well. But to be honest, usually they'll tell you that they've got a lot better on the medication. And, neurology at the moment has waits of kind of more than a year in some cases. So I think it's fine to start coca-L-dopa rather than waiting, ridiculous amounts of time to see a neurologist. If you're completely sure about the diagnosis, if the clinical signs are pretty clear. A lot of time, we sometimes, GPs kind of refer, and there's big long waits to see us. And sometimes we just advise starting medication by letter even before we've seen them. So I don't think there's any problem starting medication if you're pretty sure about the diagnosis. So that's case one. That's just a simple case, what to do in the early stages of Parkinson's. And like I say, generally speaking, just start levodopa. And whether we do it or whether you do it is a kind of moot point, but somebody to do it. Somebody's asked, why are PD meds often prescribed at odd times? I'm not going to talk about like when Parkinson's when people have had it for a few years, they started to get motor fluctuations where the symptoms fluctuate off and on all through the day, and then the timing of the medication becomes quite important. They take a medication when they wake up, and medication might last for 3 or 4 hours, and then the medication wears off and they get really bad again. And so they have to take it, let's say, every 3 or every 4 hours. So if they wake up at 7:45, they have to take it immediately then, otherwise they're not going to be very good. And then they have to take it every 3 or 4 hours after that. And that's why you might see these weird medication times. On a hospital drug chart, you might only have, let's say, 9, 2, and 6. But if somebody's got to take the meds every 4 hours and they get up at 7, that's going to be 7, 11, 3, and 7. And so you just have to stick to that. So does that answer the question about why we see these kind of odd times? It's basically just to try and keep it exact from the moment they get up to the moment they go to bed, really. So case 2, a 72-year-old chap with Parkinson's disease. He's admitted to A&E. You're called to see him in A&E. He sustained a fractured neck of femur. He's awaiting surgery. He's nil by mouth. There's no information on medication that's available. We don't know what he's on for his Parkinson's. So what are we going to do here? This is pretty common, I would think. I think many of you will have been called as a medic down to A&E, or maybe seen these guys in A&E. We just don't know what meds they're on. They've got Parkinson's. They're nil by mouth anyway. So how are we going to manage this chap? Somebody said, a lot of people are saying patch. Of course, someone's talked about Parkinson's disease calculator to change to patch. So basically, and someone says need to know Parkinson's medication first, PD nurses. Okie dokie. So let's just talk about this scenario a bit more. The first thing is you must do something, okay? They got Parkinson's. Let's say this information just isn't available. You've got to start them on something. If somebody with Parkinson's has quite advanced or quite, had Parkinson's for a few years and is fairly advanced by now, if you just stop the medication for a few hours, it can be catastrophically bad. They can get this kind of neuroleptic malignant syndrome type of thing, and they can die basically because of acute Parkinson's medication withdrawal. This has happened in Greater Manchester. I've been involved in a coroner's inquest when this happened. So it does happen. People with Parkinson's, they get seen in A&E, but we don't know what they're on, so nobody gives them anything. So the key thing is just to give them something. Everybody thinks Parkinson's medication is really complicated. but it's not complicated at all, really, because what I'm going to explain to you now is that it's just as long as you give them levodopa, that's the main thing. So levodopa, which we talked about already, it comes as Sinemet and Madapar, which are also called colcarodopa and colbenodopa. And that replaces dopamine, and it's the best, most effective, and least side effect treatment for Parkinson's disease. There's not that many drugs that we use that have a Nobel Prize. Levodopa does have a Nobel Prize. I think maybe one of the statins has one. But aside from that, it's one of the best drugs that we have for anything. Dopamine agonists such as pramipexole, ropinirole, and rotigotine. Rotigotine is available as a patch, and they mimic the action of dopamine. They're not as strong, they're not as good anti-Parkinsonian agents, and they cause much more side effects in terms of postural hypotension, nausea, and they can provoke confusion and psychosis, much more likely to do that than is levodopa. And then the other drugs, in a sense, don't matter in this scenario. Entacapone and opicapone make the levodopa work a bit better and a bit longer. Sinemet and entacapone is called Stalevo, but you don't, in the acute scenario, it doesn't matter whether they get these stuff or not. And rasagiline, selegiline, and sulfonamide make the dopamine last a little longer. So there's a subtle difference there. Entacapone and opicapone block the metabolism of levodopa in the plasma, whereas rasagiline, selegiline, and sulfonamide block the metabolism of dopamine in the brain. But again, these drugs have minor effects, which are not that important, and they're help to reduce these fluctuations, but they're not going to make any, they're not going to sort of decide whether, if someone's, going to have an acute Parkinsonian crisis. They just don't matter at all. It's the levodopa that matters. So this chap needs levodopa. We don't know what he's on. We'll just make something up then. I'm suggesting give him 125 milligrams 4 times a day of Sinemet or Madapar. Ideally, just give it orally. Oral meds are fine to give for PD before surgery. We do, deep brain stimulation and other surgeries on Parkinson's patients. They get medication pre-op. I know like anesthetists don't like anything in the stomach and all the rest of it, but one tablet is not going to be a big deal. So they can have their PD meds, the 5 minutes before surgery. It's not a problem. In fact, for longer surgeries, we're now advising they have the meds in the middle of the surgery as well. So usually that's fine with this guy, with the orthopedic guy with his fractured neck of femur. He can probably swallow fine, so we probably don't need to worry about rotigotine patches or NG tubes or anything like that. We can probably just give him some colcarodopa, 125 4 times a day. Madapar is available as Madapar dispersible, which can be dissolved in water or anything. So that might be easier to give than the tablets. If you can't swallow, yes, I agree. Ideally, give Madapar down an NG tube. If it's possible to get an NG tube down, you can put Madapar dispersible down it. And if an NG tube is really, really not possible and you really can't swallow and you've got no other choice, then yes, in that scenario, we can give a rotigotine patch. Why do I not like rotigotine patch? Why don't we just go straight to that? Because as it's a dopamine agonist, it's much more likely to provoke confusion, psychosis, and that type of thing. This guy's already at risk for having delirium because of, firstly, he's got Parkinson's, and secondly, he's had a fractured neck of femur and he's going to go to surgery. So he's at high risk for becoming delirious anyway. If you give him a rotigotine patch, you're going to give him a much higher risk for that happening. But you need to keep the dose low. So I'm suggesting give him 2 milligrams or 4 milligram patch. Remember, this is the last resort. We've got all these other options above it. But if we have to use rotigotine, we can use 2 milligrams, which is basically the starting dose, or 4 milligrams. And really, please don't use these online calculators. We're trying to sort of get them removed. These online calculators try to take whatever dose of other medications like levodopa and stuff they are on, and they convert it into a rotigotine dose, and they say, okay, you convert it all to a rotigotine patch. First of all, it's pharmacological nonsense because levodopa acts on dopamine D1, D2, D3, D4, D5 receptors, whereas rotigotine and the other agonists only act on dopamine D2. So you just cannot compare them pharmacologically. That's why levodopa is much more much more powerful. So you end up, when you use these calculators, of just ending up with humongous doses of rotigotine, like 10, 12 milligrams. You're guaranteed to make someone psychotic, especially if they're coming in with a fractured neck of femur. 2 milligrams, 4 milligrams, they're not going to be running around jumping hurdles and stuff like that, but it's enough to stop them from dying from acute sort of Parkinsonian crisis. So don't just stay away from these calculators. Give 2. I mean, we have like this kind of big clinical governance meeting. We have our guidelines for Parkinson's know by mouth, and this is what we do, which I've got it here. And we presented them to the Parkinson's team in Liverpool, and the only comment they had was, "I'm not sure about giving 4 milligrams of reticotine. Maybe you're best to stick it at 2." So this is where we're all coming from. That giving dopamine agonists to these patients who are at risk of delirium, you've got to be very careful about not provoking psychosis. And so some people asking questions about patients in the ward that just can't take oral levodopa, NG not possible. I think low dose reticotine is what you have to use in that scenario. But by low dose, I mean start on 2 milligrams. And if you need to, you can go to 4. They're not going to be walking around the ward on that stuff, but they're pretty unwell anyway. And it's going to stop them from developing a sort of acute Parkinsonian crisis, if you like. So next patient, what we've got. So here, this chap's quite important because this, I think, is probably the thing that everybody gets wrong. So I want to sort of just spend a bit of time on this chap. So this is a true case. 68-year-old chap diagnosed with Parkinson's 7 years ago. I saw him in Macclesfield. He's under a consultant in North Staffs for Parkinson's. He's on Sinemet 125 milligrams 4 times per day. He was admitted to Macclesfield with worsening Parkinson's symptoms. And then basically the referral said, please can you advise, he's having falls, he's under-treated. Please can you advise regarding how best to increase his treatment? So here's a video of him. So what do people think? Any thoughts on how to manage this chap?
Reduce treatment.
A lot of people think he's a bit dyskinetic and maybe want to think about reducing medication. So good. So this is what I wanted to get out here, get you to understand. Let's just watch this video again, because this chap seems to be a contradiction, if you like. If we start off looking at his movements, he's not got bradykinesia, so his movements are quite nice and fast. And as people have said, he's got quite a lot of problems with dyskinesia. So he's got these involuntary movements, which are a side effect of being on too much medication. But at the same time, he's got a severe gait disorder. He's freezing. He's got postural instability. He needs to be held up. He can't really walk at all. So he seems to be a slight contradiction. The dyskinesia is telling you that he's on too much dopamine, and the gait problems are telling you that his Parkinsonian symptoms are still not well controlled. This chat, I'm just going to take a sort of slight sidetrack and talk about the pedunculopontine nucleus. So when you've had Parkinson's disease for a few years, let me be, 5-10 years, or it varies. It can, when you've got fairly more advanced Parkinson's, when you've got fairly advanced Parkinson's, when it starts, the substantia nigra degenerates, but when you've had it for a few years, other parts of the brain degenerate, such as the pedunculopontine nucleus, and that's its structure here, which sits in the midbrain. And you might ask me, what does the pedunculopontine nucleus do? And they did an experiment about 30 or 40 years ago, which I'm going to recreate in cartoon form. They did an experiment using a cat. And what they did was they took this cat and they cut its head off, and they put an electrode into the cat's pedunculopontine nucleus, and they stimulate the PPN just with a nice regular stimulation, nothing complicated, and the headless cat basically walks across the bench. So it's quite a gruesome experiment, but what it tells you is that all of the circuitry you need in order to walk is located in the pedunculopontine nucleus. So even in the absence of a head, if you stimulate the pedunculopontine nucleus, then the cat can walk, presumably spurting blood out as it's going along. And so it stands to reason that if the pedunculopontine nucleus degenerates in the later stages of Parkinson's disease, you're not going to be able to walk very well because your walking center has degenerated. But the peduncular pontine nucleus does not use dopamine as a neurotransmitter, so you can bung as much dopamine as you want into them. It's not going to make their walking any better. It uses other neurotransmitters such as acetylcholine, but as of yet, we've not been able to improve this type of walking problem by manipulating acetylcholine. Someone's put anticholinergic in chat. It's actually drugs to increase acetylcholine that we've been looking at. So this is what we call levodopa resistant axial problems. It's really, really common. Axial means speech and gait, and it's really common to develop problems with speech and problems with gait which don't respond to dopamine in the later stages of Parkinson's disease. And really, there's no treatment, no drug treatment that we can give for this problem. And you're looking at therapy input like physiotherapy, speech and language therapy, occupational therapy, and so on. If we increase this chap's dopamine input, we're just going to make him more dyskinetic. We're going to cause postural hypotension. We're more likely to cause confusion and psychosis, but we're not going to make his walking any better. And so when you see people with bad walking problems like this, the key question is, what are they like in the limbs? Do they have tremor? Do they have rigidity? Do they have bradykinesia? Are they on adequate dopamine stimulation? If they don't have tremor, they don't have rigidity, they don't have bradykinesia, in fact, they have dyskinesia, meaning there's too much dopamine on board, then they're not going to respond to increasing the dopamine, in which case we don't increase PD meds. We just use things like therapy input, physio, OT, speech and language therapy, and it's more of a kind of MDT type of scenario. Someone's asked about deep brain stimulation. Deep brain stimulation doesn't help this either. Deep brain stimulation only helps symptoms that are helped by dopamine, by levodopa, but so it doesn't help dopamine resistant symptoms like this type of gait problem. So that's quite important, that guy, because I think you must be seeing this type of patient you're seeing every day on MAU, and people just don't understand what's going on, and we get called a lot to see these people. So does that make sense, what I've said there? Any questions about that chat before we move on to the next one? I think we're all okay there. So let's move on to case 4. So this next case is a 72-year-old gentleman. He's had Parkinson's for 10 years. Sorry a sec. Parkinson's